Again, as I stated, my name is Garth Reynolds. I'm the Executive Director for the Illinois Pharmacists Association, and I want to welcome you all to our very important town hall this evening on workplace issues and the impact on patient safety. Yeah, 1 second again here. So our quick agenda this evening, again, we're finishing our introduction and overview over the next couple of slides, but I do want to go over specifics on a couple of items that most of you may not be aware of. And I do want to make sure that everyone is aware of some important tools that can help with assisting in not only providing information to you, but also helping provide information to the profession about what is going on in your workplace. And then we'll talk about the upcoming special Board of Pharmacy meeting that is happening later on this month. And then, of course, most importantly, your time. And we want to hear from you, and we want to be able to take down the important pieces of information that you need to share with us this evening. And then we'll talk about some next steps. And there are some next steps. This isn't just a one and done. This is being a multiple part of a continuing conversation that we've been having over the last number of years, and most importantly, focused over probably the last 5 or 6, especially pre-pandemic and now. And but we do want to make sure that we are not missing anything that's especially important that we share with stakeholders who can make a difference. First off, I want to share data that's collected every month from the IPhA Wellbeing Index. And the IPhA Wellbeing Index was developed in coordination with the Mayo Clinic, and we'll talk a little bit more about what it entails. But it really looks at a number of factors in trying to look at your personal stress level and your burnout potential. And if we look at data, and this data is divided into district reports. NABP is divided into 8 districts, and those reports are sent out to the various districts for NABP. We're part of District 4, which includes Illinois, Indiana, Ohio, Michigan, and Wisconsin. And you'll see here I highlighted our most recent survey data from the November of this past November, and we were ranked 24th out of 50. This is not a listing where you want to be up or higher on the list. And so this means, and if you look at where we started out when the very first version of this report became available, this index became available in April of 2020, we were 30 out of 50. So if anything, we're actually going severely backwards. And you can see over time that we've kind of changed, but we've really kind of hovered into that 24 to 26 state range, which means we've got a lot of work to do, and making sure that we properly recognize what's going on in the workplace and how that's impacting your mental health and impacting your patients. But I do want to encourage you, if you have not, and I know we have maybe about 300 or so individuals that are reporting on a regular basis to the Wellbeing Index. We do not see any of the individual reports. We get the aggregate data as you see as presented in those reports that are not only sent to the state associations, they're also sent to the State Board of Pharmacy. So our state board, or at least our Department of Financial and Professional Regulation, receives a copy of that report every month as it comes out. And we share it with the board as well to make sure that they get it as well. But the Wellbeing Index itself, it is a online screening tool, and it's done, as I said, in coordination with the Mayo Clinic. It helps evaluate fatigue, depression, burnout, anxiety, and stress, and assess your overall well-being. And it's done with a very short 9-question survey. And again, you don't have to be an IPhA member to utilize this important tool, but we'll have ways that you can access it as we go through the town hall. And there is an invitation code that just allows the index to know that the data is being collected for you and for IPhA. One other important tool as we started throughout the profession to analyze how we can best address workplace issues and look at well-being of our personnel back in 2019, in July 2019, there was a consensus conference of 85 individuals throughout the pharmacy profession, and Illinois Pharmacists Association was one of the representatives in this conference. And we came up with 50 recommendations on how to start looking at this from the whole continuum of students to technicians to pharmacists. What are the factors impacting this, from payment to workflow designs to metrics? But one of the important elements was also looking at data, and that we needed to find more research, because as we know, and as we all are, we're scientists, so we need evidence-based data. Even though we have a lot of experience and information that we'll gather even this evening, but we've also gathered in other avenues. But we really need this data to be able to show empirical data back to stakeholders like the boards of pharmacy. And this data is collected as a project between the American Pharmacists Association and NASPA, the National Alliance of State Pharmacy Associations. And we helped institute this reporting back in November of 2021. So we have over 2 years of data that is submitted and aggregated and processed and published for review. And you can actually go out and look at these reports. IPhA hosts these reports on behalf of the Alliance for Patient Medication Safety. And APMS is actually, it's a subsidiary of NASPA, and it's a national patient safety organization. And it actually provides, as a majority of its service, helps provide quality assurance and medication reporting capabilities for community pharmacies and health system and ambulatory care pharmacies throughout the country. And we were able to utilize and repurpose part of their capabilities to help make sure that we have a confidential and anonymous processing portal. There was a question in the chat that's very good about this. The reporting portal here, especially for the pharmacy workplace and well-being reporting, is for any pharmacy personnel. You can be a pharmacist, a technician, or a student. We need to understand what's impacting all members of our profession and our work teams. And I just want to show just a snippet of some of the data. And this is looking just at the August 2022 report. And this is actually based off of a presentation that I gave with my colleagues from Indiana and Wisconsin to the District 4 meeting last year, which was the annual meeting of our region's Board of Pharmacies. And if you look at this data, there's two different types. There's the analysis reports and the snapshot reports. And the snapshots kind of help give us a little bit of what new information is coming in. But these analyst reports, there's not when these reports, the information is, for a lot of us, we would read it and we'd be like, well, duh, this is what's happening. But like I said, we need to put the information to create the data so we can create the change. And one thing that was very concerning for myself when I was looking at this and with my colleagues that I presented at the meeting, we were looking at harassment being an increased issue of pharmacy staffs. And as you see here in the title, it says harassment of pharmacy staff is real. And it's not something that's made up, and it's something that we need to take very seriously. And we're looking at not only just verbal and emotional harassment, sexual harassment, but threats to physical harm, and of course, discrimination. And all these different types of harassment. And one of the things and the aspects that came out of this report that we actually presented as a challenge back to the boards of pharmacy was more and more of this violence and harassment is coming from our patient base. And I proposed a challenge to the boards of pharmacy in the room that day, stating that the boards of pharmacy are there to protect the public from the profession. But what do we do when we now have a new public safety hazard that is the patient? And how do we best address that through policy? Now, we don't have quite legislative answers for that yet, but it's something we have to start asking ourselves and how we address this so we can help better protect our pharmacy teams in delivering safe patient care. And when we were looking at well-being, the factors that were brought forth in this analysis have already started to show that increased stress, increased burnout, weakening family and personal relationships, and lessened happiness are all interrelated and are not presented in isolation, which means that all of these factors are connected when it comes to our overall analysis of well-being. One thing I want to make sure as we go through is I'm encouraging you to submit your information. And the one thing about the Power Portal, we're definitely wanting your negative experiences, but we also want to know if you happen to be in a workplace that's doing something that's working. We also want the positive examples put in too, so we can help build better practices. But one thing I want to remind everyone is that submissions to the Power Portal and the Wellbeing Index are not designed to replace an official complaint or submission to the Board of Pharmacy, and that the data from the Power Portal and Wellbeing Index are only reported in aggregate, and they're never expressed to represent information of individual cases or submissions. And this is one thing with the Power Portal in particular. I do want to give thanks to a lot of individuals from Illinois. We are one of the higher reporting states. Now, again, that's something I'm not wanting to, put a medal around our neck for, because means we have a lot of problems that we need to get addressed. But I do want to thank those that have actually put and cataloged their experiences so we can learn from them and so we can process the data to help make sure that we're making better changes for the future. As we look through these examples, the other items that we have processed through from the recommendations was looking at, we really need to change and address, what do we expect out of a workplace? And what should a pharmacy team employee expect from their workplace? And so out of that discussion between IPhA and the National Alliance of State Pharmacy Associations came the pharmacist fundamental responsibilities and rights. And I'm very pleased that this has come out. This and was president-elect and president of NASPA, actually, as this was being deployed. And this is really now our next fundamental document of the profession. We have the oath of the pharmacist, we have the code of ethics, and now we have the fundamental responsibilities and rights. Now, granted, having a document doesn't mean changes happen overnight, but it establishes that as a profession, we have expectations. And with those expectations, we can now examine how our workplaces can change. And we have a number of organizations besides IPhA and NASPA that have signed on and endorsed the fundamental rights so far. And you'll see a number of national associations. Illinois Pharmacists Association is also signed on, and a number of schools. And I pulled the schools that are represented under the IPhA umbrella that have endorsed the fundamental rights and responsibilities document. Now, of course, there's dozens more organizations and colleges that have also submitted that. And that doesn't mean those that haven't don't endorse it. It just means that they haven't put that pen to paper. So we always encourage those to continue to look at ways of making sure that they can endorse this important endeavor forward. As you'll see tonight, we'll have a couple of different QR codes for you to utilize. And if you want to go ahead and engage and sign up for the IPhA Wellbeing Index, I've put this QR code here. We've also put a QR code here for the Power Portal if you want to start engaging to file a report, or if you feel you want to report a complaint to the Board of Pharmacy, so the department can examine the issue that you've experienced. We've included that QR code there as well. And remember, as I stated earlier, Power Portal submissions are not shared to the states in a way that can be actionable to the Board of Pharmacy. And I know that we communicate a lot of what's going on in our workplaces through multiple different means, whether it's social media or sharing peer-to-peer experiences. But we really have to follow a complaint process. Unfortunately, for the boards to really take a lot of action, we're a complaint-driven process. So I highly encourage you to file an official complaint. Even if you, after you look at this, you have questions, feel free to call the office. We'll be glad to step through that with you. If you need representation, we have pharmacist attorneys or other attorneys that we can make recommendations for that can help you with any legal representation that you may have. One thing I want to remind everyone when it comes to filing a complaint with the department, Illinois is one of a couple of states where you can actually file anonymously. And so if you do have concerns about the situation, you do have that protection to be able to file anonymously. I do believe you do have to submit your email address. So if the inspector who gets assigned the report has questions, they can reach out to you. But that is the only way they if they have any follow-up questions. But why was the reason that we pulled all this special town hall together? It's not that we just found out that workplace issues are a problem. We've known that workplace issues have been a concern and an increasing concern for a number of years. Why we've brought everyone together tonight, and I'm really pleased with the turnout that we've had from across the profession and across the state, is that the Board of Pharmacy at the November meeting decided to have a special meeting on workplace issues. And that meeting has now been announced, and it has officially been announced for December 19th in Chicago. And IPHA will be there, and we want to make sure that we're helping provide an enhancement and empowering your voice and making sure that we are not forgetting an aspect that we haven't talked with the Board of Pharmacy about. There is not a Board of Pharmacy meeting that has not gone by over the last number of years where we have been expressing our concerns and increasing concerns on workplace issues and where there needs to be some remedies and some of the factors that are impending on and increasing a lot of the pressures when it comes to workplace issues. And before I turn it over, I know we have a couple additional questions here in the chat, and let me try to address those real quick. We have first question is, what impact do you think wages play on mental health of pharmacists? And would it be easier to deal with the stresses of the workplace if we were paid fairly? Walgreens hasn't given a raise in 5 years, and it makes it harder to deal with the issues we face when I know my work isn't valued. And I think, you know, as we look at with any type of work that is um, any type of work or position that we're in, we always want to make sure that we're being properly reimbursed. And whether that's through a pharmacy, making sure that they're getting properly paid, or making sure that there's proper salaries and rates of pay for our pharmacy teams. And I think that sometimes salary rates and wage rates can have an impact on an individual's personal and mental health. And so, you know, those are things that we wanted to discuss, and I'm glad that you brought this up. And I'm not going to name individuals as they put them, even though they did put it in the open part of the chat, and that's fine. But I really want to make sure we have this as an open environment tonight, and there's nothing that anyone can say that's wrong. So there can be things that can maybe considered negative, and that's okay, but there's things that can be positive, and that's okay. I want everyone to understand that this is a safe place tonight. We're not going to engage in debate, but I want to make sure that everyone can be heard. And we did have one other question about how many are on the call. And right now, I know that we have at least 228 in the room. And it looks like we've got a number of people on Facebook as well. I'm trying to simulcast live this, and we'll see how that part of it goes. But I want to pull back and not say any more so we can bring your voices to the microphone. And if those of you who want to speak, if you don't mind starting to do that request to raise your hand, so then I can go ahead and unmute you so that you can go ahead and provide your comments. I also have comments from individuals who were not able to be with us tonight, or decided that they were concerned about saying what they wanted to say and it being attached to them, whether by name or by voice. And so we will share those comments with everyone as well, because even though they may not be speaking in the microphone directly, their voice is just as equally as important. Couple more questions, and then as we'll address these as we go through, and then we'll turn the microphone over to you. Why are PBMs the root cause of work conditions, low reimbursements, and low staff? It is a major root cause. There's a lot of evidence to show this, as we've had a continued decades worth of improper reimbursements at an entire system level. And I know a lot of times when PBM reimbursements are brought up, most people may think it's just a community pharmacy problem of an independent nature, but this impacts the one store owner all the way to the largest corporations in our country. And unfortunately, we have some of the corporations within our own pharmacy profession that are directly and systematically causing the pain that a lot of our pharmacy teams are experiencing. And I would go even beyond just saying that it's reimbursement structures. It's also insurance designs. It's whenever we have a major insurance company that puts in designs that forces mail order to their facilities or to their community retail pharmacy locations, and then doesn't have proper staffing, that's not appropriate. And there needs to be changes in how that is looked at. And so, yes, PBMs are a major issue in how we continue to address this issue. But I'm going to pause with some of the questions, and we have we have people who've raised their hands, and I'm going to go ahead and address those, and we'll come back to the questions. Joseph, you're able to speak. You may have to unmute on your side.
Okay, sorry, thanks.
No problem.
So I guess the question or this thought I had was, I appreciate you setting this up, first of all, but my concern was like what had to deal with breaks that seemed to be a struggle that a number of pharmacists are having issues trying to actually get breaks in. The state, we were able to get updated laws with the mandated breaks and rest periods being put in, and companies tend to twist it in their favor as far as setting things up. And I guess my question was, or comment was, just about, is there a way to get policies updated so that breaks can be put into schedules automatically? I mean, where the state would allow us to be able to do that.
You mean so like a scheduled break?
Right. I mean,
Yeah.
it says now we're able to get, a 15-minute break after so many hours, but to get those actually taken without being pressured by management, as far as to be able to step out, where to get some type of something in writing that says that we have the ability to have it actually put into our schedule, where if I'm forced to take a lunch at 11 a.m., at 1:15 I should be able to walk out again for my 15-minute rest period or break period, for example.
Yeah. I would say, at least from our cursory, knowledge of, of the Pharmacy Practice Act language, there's nothing in the act that would prevent a break from being scheduled, but there also needs to be an expectation of what breaks should be, as you're rightfully saying here. So one of the comments that I just made a note on that, is making sure that maybe the department, through the chief inspector or another avenue, can provide additional expectation of how breaks should be utilized. And if that means there needs to be additional language, that's something that could also be pursued as well. So I think you bring up a very valid point there.
Thanks.
No problem. Is there anything else that you want to share?
Well, I guess not at this point. I'm going to listen a little bit more, and I might pop in and a little
fine.
later.
Okay, I'm going to place you back on mute. Not a problem.
Thanks. Yeah.
I did see someone else that had asked to speak. and they lower their hand. If they wish to do that again, that's fine. We'll be glad to address that. And we want to make sure that this is as interactive as possible. One of the other questions we had is in the questions is, why is there not a conflict of interest required for state board members? If the retail giants are on the state board, nothing will change. I have filed numerous complaints and they've all been ignored. Retail pharmacy needs tech hours and increased tech pay. That's all. And why is telepharmacy being allowed? So, um, couple of great questions there. I do know that as state appointees through the governor's office, they do have to file some conflicts of interest, and the department does, through their attorneys, are supposed to make sure that board members remove themselves from cases where they would be in conflict or an ethical issue with the employer that they are involved with. But there may need to be some strengthening of that, and that's something that we'll look at and bring to the board as a concern. And that retail pharmacy needs tech hours and increased tech pay. That's a very valid point, one that I know we've been looking at for a number of years as well. And then why is telepharmacy being allowed? And I know that I'm not referring just to telepharmacy as the practice itself. I'm assuming it's more about how, because there are telepharmacy practices in the state, if we would remove them, they would not, those communities just would not have access to pharmacy services. But we do know now that there has been some some modified use of telepharmacies, probably not envisioned with the original intent of telepharmacy, where we're utilizing them now in some of the chain practice settings. And so that is something that needs to be concerned about. And if those have attended the State Board of Pharmacy meetings over the last number of months, have known that we have been very vocal about our concerns about telepharmacy being used in high volume practice settings, and how that is just a danger of patient safety waiting to happen. So it's a very great point, and I'm glad that someone had brought that up this evening. I'm going to turn it over. We have another individuals wanting to speak. Suresh, I've unmuted your line. You may still have to unmute yourself to be able to speak.
Hi, Garth. Can you hear me?
I can go right ahead.
Okay, good. Hey, thanks, Garth, setting these up for. I'm Suresh Patel. I'm a pharmacist at Walgreens for a long time. One of the reasons I see the pharmacist burnout and the mental and physical well-being being affected is working long hours. Working 12 hours with not having taken proper breaks, lunch breaks, or the meal breaks, that's really affecting the mental and physical well-being. And I believe this, and I'm glad that the topic of this Zoom call is about the well-being and the impact on the patient safety. So the question is that when you meet the Board of Pharmacy on the 19th of December, I'm planning on being there as well. How can we address this 12-hour shift? No healthcare professionals need to work 12 hours a day. Is that like a work that we are working on it to reduce the hour, maybe 10 hours? No pharmacist or no healthcare provider should work 12 hours. That's what I'm trying to say.
Yeah, not a problem, Suresh. Thank you very much for bringing that up. And I know work hours were discussed heavily. Limitations were looked at extensively when we had the collaborative pharmaceutical task force. And I know a lot of the discussions and even comments I know that I even made during that discussion, it really came back down to the economics and reimbursement levels, because one of the aspects that has to be recognized as how language is deployed in the Pharmacy Practice Act, that it impacts all pharmacy practice settings across the board, and that it would have been a hindrance economically for some practices to have an 8-hour limitation. They quite frankly couldn't afford additional staff to make sure that they were open for their patients. But that doesn't mean that there's not practices that are abusing situations. So again, all of these comments are valid, and we want to make sure that it gives us opportunities to look at future ideas. So thank you.
Thank you, Garth.
No problem. Let's see here. Fazia, and if I mispronounce your name, my apologies. I've unmuted your line or allowed you to talk, and you may still have to unmute yourself to be able to speak. Looks like you have unmuted your microphone. Please go right ahead.
Hi. Well, actually, so my name is Carl,
Oh,
but
okay.
but one of my big questions was okay. So Suresh mentioned long shifts, but what about shifts where the pharmacist is working alone? Because in my many years as a pharmacist, 10 years plus, I've had so many times where I was the only person working. And trying to run a drive-through and pick up and drop off and answer all the phone calls and do immunizations and everything like that. It's absolutely ridiculous. There's money for technician scheduling, and if so I know some states do things where they have a like a pharmacist to technician ratio. What are the options of doing something like that in Illinois? Because that would be I think no pharmacist should ever have to work by themselves.
Well, thank you very much for your comments on that, and I can definitely appreciate working alone from some of my own experience when I was still behind the counter on a regular basis myself. So you do have to be very good at multitasking and addressing situations as they come up. So I can only understand the situations as they are now. We've had increased service requests as well. But I know that there have been states that have had good and bad experiences with ratios. And just for full disclosure, our association does have policy that we're not in favor of ratios, mainly because we're concerned with how they fit for all practice settings. But again, I'm not saying that it's not a valid comment. I just wanted to be full disclosure there. But I also want to make sure that we look at the situations of making sure that you're looking at proper workforce balance with your staffing. And that is something that we have addressed also in our policy through the association, is that and we directly recognize something that North Carolina had done actually well over 20 years ago, with looking at limitations for making recommendations for um, number of prescriptions that a pharmacist would process. And of course, that study and all that was done before we started doing patient care services on a regular basis. So, and that was talking about 150 prescriptions in an 8-hour shift. Now, again, that wasn't talking about vaccines or point of care testing, a lot of the other important responsibilities that we have as a community provider. But so no, I really appreciate that openness and bringing that forward. So thank you. Robin, I've unmuted you, and please go right ahead. You may still have to unmute on your line.
Okay, can you hear me?
I can go right ahead.
Okay, my question is it considered unlawful or wrongful termination if an employer terminates you and gives you the reason for that your values don't align with the company values, even though you had no um, write-ups or no disciplinary actions taken against you? And if so, what options can you pursue?
Right, and Robin, feel free after this you'll see my email information later on in the meeting this evening. Feel free to get a hold of me, and we can help provide you information for counsel if you wish to take a look at that. But just one general business discussion that we do need to discuss with Illinois. Illinois, like many states, is an at-will hire and fire state. So as long as we're not violating someone's federally recognized or state recognized civil rights or other recognized employment rights, there doesn't have to be a cause for termination. And
Oh,
so that is that, and that's been something that I think comes up time and time again, whether you're talking about pharmacy or healthcare or any other industry. I know that comes up time and time again in the General Assembly. in
Well, could that
discussion.
could be considered some type of civil rights or
It would just depend on the
discrimination?
it would depend on the
Discrimination.
aspects of the case, and that's why I said I'll have my email address and phone number for you to get a hold of me later, and I'll be able to help provide you with recommendations where you could reach out for legal counsel on that. I'm not a lawyer, and I don't
Okay,
I don't want to pretend to be one and provide legal advice on that. So,
thank you.
no problem. I did see a couple other people that had put their name. Oh, Shane, here you go. Shane, go right ahead. You may have to unmute on your line. Thank you very much for joining us, sir.
Hey, Garth, this is Shane Jereminsky. I'm calling in from California in support. I just wanted to address, we get this common question all the time out here from people across the country. I run a page on Facebook that has a lot of pharmacists. 12-hour shifts. There's a lot less of those in California because California labor law. So I just wanted to see in Illinois, anyone who works more than 8 hours, is it mandatory that they're getting time and a half for anything over 8 hours or double time for anything over 12?
No, we don't have any type of stipulations like that.
Okay. And the only other thing I wanted to mention is that Walgreens and CVS operate profitably in California where there are labor laws like that. So, I mean, just addressing the idea that like saying, well, we can't really do that. You have to work long hours. We have lots of places where there are overlap. And if the business model doesn't sustain two pharmacists with overlap, then you have a pharmacist still working those shifts, but they're getting compensated for it. So while it's still very difficult to work a 12-hour shift, at least they're getting the compensation for it.
Well, excellent. And Shane, I know you have some of my contact information, so please feel free to share some of that labor language with me. I've known some of the revisions that have been done in the Pharmacy Practice Act on additional empowerment language that has been given to the PICs. I was hoping that would have been expanded to pharmacists on duty, but I'm glad to see at least with PICs. So I'd be glad to take a look at that language. We're still available for questions for those that wish to speak. If not, I'll go back to questions that we received here in the Q&A. If a pharmacist is working and mandated policies requires 30-minute break, how he will serve the patients effectively with no help? Again, that's definitely a valid comment, and I think that we need to take a look at operationally of making sure how the pharmacy closes during those times. So, Bob, let me get you where you can talk here. Go ahead, Bob. You may have to unmute your line.
Can you hear me, Garth?
I can. Go right ahead, sir.
Okay, Garth.
Good to hear you.
We've talked about some of these questions for over 40 years.
Mm-hmm.
And it's the same questions and the same problems that keep coming up. We've got to, and 40 years ago, we did comparable amounts of work, but we had many more technician hours. And I think that's the key to really workplace, burnout and stress. If you've got enough help, and I'm even saying, having more than one pharmacist on duty at a time, that goes quite a long way towards making your day better. I mean, there's so many pharmacists, they get out of pharmacy school, they work alone, they get beat up all day long. There's no way that you can communicate with anybody. You don't have enough tech help. You're going from, you come in 2 hours early, you stay an hour late on a 12-hour day, you're working 15 hours a day without, like, as that's been said, by yourself for a majority of the time from 9 o'clock till 4. I mean, these are things that just can't continue. They just can't. And, we've talked about it a long time. Limiting the number of scripts doesn't work because I could probably fill 30 birth control pills in 1 hour, but yet there might be, a time when you can't do more than 4 or 5 scripts in an hour, depending on how many phone calls and how many issues you have to look up. And then tech to pharmacist ratio doesn't always work out either, because, if they make a 1-to-1 ratio, and say you're in a store where you're only filling 10 scripts an hour, that wouldn't work out either, because then costs go up. So this is something we beat around all the time. But my main thing to say is we really do need to have more than one pharmacist on at a time, at least for some overlap. And we really need the technician help to bring things to a more sane level, just to get the pressure cooker off.
No, I agree. And thank you, Bob, for your comment. And don't unmute just yet. I wanted to see if I could pressure you a little bit with a question to you. As a former member of the State Board of Pharmacy, because I don't want to ask any current members that may be in that could put themselves in a situation, could you kind of give some feedback on your experience on one of our previous questions? Was there a conflict of interest policy? If there was a case that came up that involved your employer, were there stipulations where you had to remove yourself and et cetera?
Absolutely. You have to remove yourself if you're going to be on a case and it has anything to do with your job. That's 100% true. There is something when I was on the Board of Pharmacy for quite a number of years, I was the only practicing pharmacist on the board. So you're having decisions made by people who are mainly management, middle management and above, vice presidents of Walgreens and so forth. And, those kinds of decisions looking from a global perspective are great. You've got to have that on there. But without having somebody that actually day to day works and can say, this is not going to, this is not going to fly. This is not going to be something that can go on. I think if you're looking on being judged by somebody, and I did have a lot of cases where they picked me because I practiced and still knew what it was like to get your brains bashed in. I'll be honest with you, I've seen pharmacists set up by corporations to where they were set up to fail. And that was a great way of getting rid of somebody. You can just set them up to fail. And it's horrible. It's absolutely horrible. So yeah, that from my perspective, no, I never sat on any cases where I had my work had an interest in it. But that being said, it's, you're still going to be on cases where, you're going to have people judging you for what you've done behind the counter. Right. I've had district managers tell me, don't hide behind patient safety. Okay. And, you explain that to somebody who works in management. Oh yeah, I can understand that. No, you can't do that. Patient safety, when I brought it up, it was thrown in my face like, oh, that's just an excuse because you don't want to work that hard. So yeah, I've seen it.
Yeah. Well, Bob, I greatly appreciate you expanding upon that and allowing me to ask you a question back. So thank you.
My pleasure.
We'll go ahead and go to Stacy next. You may have to unmute on your side.
Good evening.
Good
My
evening.
name is Stacy. I'm a pharmacy technician at Walmart. I have one of the most amazing companies to work for. Everybody is so short-staffed. We have the staff. Here's my problem. All of these other pharmacies aren't staffing or even keeping their doors open on business days or weekends. And we're getting all of this overflow of all these patients who can't get their prescriptions at pharmacies, who can't keep staff, are closed, can't get them, So our staffed pharmacy all of a sudden turns into a war zone now also because CVS, Walgreens, Kroger's can't stay open. So, now we're running rampant. And I have technicians and I have pharmacists. I just can't understand how these places can't stay open. So I'm just thinking, is there any end to that? So it all just levels out,
Right. And I know you bring up a very, very good issue that I'll answer two things very quickly on that. In the most recent rules change to the Pharmacy Practice Act rules that went into effect in early June, if a pharmacy has a closure of that type for more than 72 hours, that's considered an unscheduled change of their hours, because whenever a pharmacy applies for their application and their license, they have to state what their hours are. And now the department's wanting to know if it goes beyond 72 hours, they need to be notified of that change. But that could mean that there needs to be something more done to help address that issue as well, because you could, change locations all the time so you don't ever hit that 72-hour window if you're having a tremendous labor shortage. Secondly, on that, there is a change in pharmacy law that does go into effect on January 1, where we will now have the ability to have a new pharmacy personnel team member. For lack of better phrasing, a pharmacy cashier or support staff, that they don't have to be registered with the department. They're not a technician, so they can handle non-drug related activities, but they can sell verified bagged prescriptions, and be able to handle other non-patient care or prescription dispensing activities in the pharmacy. So yes, it's not a solution, but it is something that we worked with Senator Chapin Rose because of the issue that you brought forward, Stacy, particularly what his experience was in the Champaign area. And I know it happens in the Chicagoland area and other parts of the state, including where you are in Harrisburg, that we have, and I know it's happened here in Springfield as well, where we've had a number of pharmacies at very short notice with closure changes or change of schedules, and it puts the patient into a bind. And this language also allows for trained personnel to be able to have access to the pharmacy to be able to sell a prescription in the same manner as we sell prescriptions when a pharmacist is on break or at lunch. So again, that goes effective on January 1, and we'll have more details on that in our law review later on here in the coming days. So I'm gonna go ahead and go to Bedrea.
Garth, thank you. I have really enjoyed listening to the discussion tonight, and a couple of people have mentioned the pharmacy to technician ratios and those not being reasonable to a point, because we might have lower volume pharmacies. I would appreciate feedback, maybe in the chat directly to you, that you might be able to pull later, on having minimum number of hours based on prescription volume. And when we talk about a minimum number of hours based on prescription volume, I'm talking about the bare minimums that you would need in order to be able to function safely. I'm not talking about ideals. I'm talking about what is the bare minimum in order to be able to function safely. I personally, for me, it would be helpful to have some idea of people's thoughts on that. Thank you.
Thank you, Andrea. And you brought up a really good point. One that I'm going to skip ahead just real quick to come back is that, and you see the QR code that's listed and up here next to the file a complaint with the department. It says workplace condition survey. I know a lot of us are surveyed to death, but we are asking to help collect data so that we can present this to the Board of Pharmacy and later on this month. To have you go through this, and please provide us information about your work setting. It is not asking you your name or your email. We want to know about what you're experiencing and asking you, in your opinion, just what Bedrea was talking about. What type of tech hours would you feel or comfortable, or your pharmacist hours, those type of things. So if you would please make sure to complete that survey and encourage your peers that aren't able to join us to complete that as well. Joe, you've got your hand raised again. You are unmuted. Go right ahead.
Hi, sorry about that. Yeah, I just obviously been kind of listening. So, for the Chicagoland area, I thought I would at least mention this. So I work for Walgreens. We have a union that represents the staff pharmacists and market pharmacists for the Chicagoland area. And you would think that would mean that we are, king of the hill. And unfortunately, we're not, because of lack of support. For having over 900 plus people that we are responsible for, we have minimal support, and that makes it difficult to challenge a large company like Walgreens. But I just find it interesting. There was a comment about the number of hours of shifts, and I'll give you an example. The company said, "Oh, we're listening to our employees, and the hours are too long." So they went ahead and reduced hours in 110 stores in our area. And that sounds great, but all those people were 80-hour employees, and they've become a hybrid staff / market pharmacist for the company. because we can't hire anybody. All right, so that's I mean, I work in a 12-hour store. It's a long day, but I have my set hours, you know, and they've forced people to now work 64 hours maybe at their home store, and then they have to float to cover, you know, stores that aren't open. So that's one thing that is, so you, in response to like just demanding that happen, I would hope like the individuals in California, that'd be great if they said, hey, we're going to still have coverage and people are going to get their hours still. And if you do happen to be in this store and you're going to get paid extra for doing that, that would be a different story. But that doesn't happen right now. You know, like on that telepharmacy issue. My biggest question to, if you could ask the board, is what was the reason to reduce the mileage of a 20-mile radius of having another pharmacy around you in order to have that telepharmacy be there? That apparently has been taken out. And I can't understand in the Chicagoland area or in a number of, you know, busy cities where telepharmacy plays a role other than the purpose is to reduce the workforce and to save money, you know. So that's a point on that. And then, you know, I think the person that works for Walmart was talking about, you know, oh, they have plenty of help and, you know, all the other ones are closing. Well, you know, it's such a twisted group or problem. You know, you have a company that doesn't want to pay technicians and their pharmacists a reasonable wage. So they can't attract good people. And then once you get somebody, they don't provide the training that they used to provide years ago. I've been with the company 34 years. Okay. So I've seen a lot. And we had tech training programs. We had the ability to train through our software, to send mistakes back to the person that was typing them in so they can learn from their mistakes. Like I said, there was all types of things available that have all gone to the wayside, all in the name of saving money. And it's just a vicious cycle, right? We try to get somebody, we put in X amount of hours to try to train that person, and then they quit because they're just thrown out into the water with the sharks. And we don't have the ability to help them grow to become a long-term employee. You know, that's that, at least that's what I see, you know. And I think there was one other point, sorry, that was about, you know, working by yourself. I don't know who that individual was. I would personally, like if it's with Walgreens, I would be reaching out to my DM or healthcare supervisor, like immediately saying that, you know what, I'm going to be stuck with no one tonight. And if I, you know, I'm closing the drive-through, I'm going to put a sign up that says I am by myself and you're going to have to come in. You're going to have to make adjustments. And, you know, so from my aspect of it, I guess for who I represent, you know, I am asking if you're on the call, which I hope I did try to send a message that, you know, if you're having problems like this, where you're getting stuck without having any help with your schedules and the scheduling of the flu shots and all this other stuff, if you don't tell us, we can't file. Like, we have a way to report. We have a contract and there's things that have to be followed. But if you guys aren't stepping up to do something about it, we can't file a grievance. We can't make the company try to make a change. So I don't want to get on a pulpit, so I apologize, but like,
No, you're good.
you know, well, thank you.
No problem. You bring up some really good points, and one about mileage. I'd really like to know where 20 miles may have been, because I don't believe we ever had that in the act about mileage, but I know a number of states do. We're one of the few states that don't have a mileage, but be glad to take a look at that and work and ask that with you, because I know there's been pharmacies that some of the telepharmacies that are up in in the urban areas up in Chicago in particular are trying to help establish pharmacies in high Medicaid areas and of communities of need where you financially can't justify a full footprint of a pharmacy. And telepharmacy, whenever, because I was on the 2006-7 task force where telepharmacy was fleshed out, it was never the intent that it was to be used in high volume operations ever. And that's something we got to look at, because you trying to manage a high volume store and then try to manage even medium to higher volume remote stores is way too much.
I guess
And
sorry.
no, go ahead. Sorry, I stepped on you.
So the other question I would have though with that, how are some of these stores functioning with narcotics and controlled substance issues, safe, like just getting into the safe access when they go into telepharmacy mode? If there's no pharmacist on staff, I mean, I guess I'm just not sure how the process works. It just seems like there's not
Right.
enough information on it.
Right, and especially with, it sounds like with your corporation that there's a corporate policy where controlled substances are only accessible by the pharmacist. So that's not a state law, and so the telepharmacies in Illinois can have access to controls, but depending on your corporate policies, that may be a barrier, and that's a very valid point. If you go into telepharmacy mode for that location, how are you to serve patients where the technicians don't have the access according to policy? So you bring up a very valid question. And one of the things I want to point out that you kind of based off some of your comments, Joe, and some of the others, and I'm really glad you brought up that whole point about you have to report if there's issues going on. And it sounds like you guys have a reporting process, and that's great. But it goes back to what I was saying earlier about the complaint process. One of the items that we put into place with the collaborative pharmaceutical task force recommendations that went into effect in 2020, part of that was putting in a series of violations about conditions that would hinder patient safety in a proper workplace. And some of that was also looking at abolishing some metrics. Now, granted, that did change some metrics, but I know some still exist. But it did try to address a lot of these issues, but with it being considered violations, you have to file a complaint. Or because the board, one of the things that we have advocated for well over a decade since I've been in this position, that we need more inspectors. We only have 5 that cover the entire state. This state's way too big, and the number of stores are divvied up pretty much, or at least the last time I knew about this, they were divvied up pretty much numerically. Well, that works well in the more urban part of the state, but it gives one inspector, for instance, who's based out of Springfield, he has Bloomington to Cairo. The inspectors are chasing complaints, and they're not able to do as many proactive investigations as they should. So again, I'll get off my soapbox on things because we're here to hear from you and not hear me get on my soapbox. So I'm going to go ahead and go to some more of the comments and questions. There was a question here. What are IPHA's thoughts on a pharmacy system? I'm assuming like North Dakota. I'm assuming that they may be referring to that there has to be a pharmacist as an owner of a pharmacy to be able to operate in North Dakota. And they said, could removal of chain pharmacies help improve conditions? Illinois used to have that requirement many, many, many moons ago, and I know it was removed, I want to say late 80s, early 90s, that you had to have at least a majority of a pharmacist be a majority owner of a pharmacy. And I think those type of policies could be interesting. I'm not sure that that's something that could be implemented at this stage, but hey, I've seen stranger things happen in my tenure. So next question was on metrics, that metrics need to be abolished. And that's another reason I just talked about the issues of the violations. And if anyone has questions about what they're experiencing, if it fits within the language of the violations, we can help provide some interpretation of the language. But again, we're not an attorney, but we can help link you with one if you feel, but could help with encouraging you to at least file a complaint to have it taken a look at. Metrics need to be abolished. I had a supervisor come in today and threaten us about verified by promise time, and we are short-staffed. They said they were drowning. I'm worried about harming patients because I'm worried about being written up and trying to speed up. Something has got to give. I am so sick and depressed about tone-deaf corporate policies. Thank you very much for sharing that comment, and it's one that I've heard over and over again. Bob raised his hand again, and you're unmuted. Go ahead, Bob.
Hi, Garth. Thanks again. Mine was more of a statement earlier, just to say that maybe we need to give the pharmacist in charge, or even the pharmacist on duty, if it's an unsafe situation that they're working in. And believe me, there's a lot of unsafe situations to work in out there. The authority to close the pharmacy.
Mhm.
If you don't have enough help and you can't make it, you know, or somebody feels threatened, and I, you know, when I was a lot younger and had a lot less to lose,
Right.
I did. You know, I was in a situation untenable in the mid 80s, and, you know, a new computer system started on the day that my tech called in. She was going to be off for a week, and I had a pharmacist training me and standing next to me while I was filling prescriptions and transferring them to the new system by myself and ringing the cash register.
Right.
And when I got done with that day, I called up. I said, if I don't have tech help tomorrow morning, I said, I've got to put a padlock on. I said, and I'm calling the board of pharmacy, which the owner was out of state, so he didn't know whether I could do it or not. But maybe we need something like that.
Right. Well, you bring a very good point, Bob, and I know that I believe California in some of their recent language that they put out gave that power to the PIC. But I was looking at it saying, you know, we need to be looking at more of pharmacist on duty powers to be able to help enhance some of those situations. Because again, if you, Bob, as you were saying, if you were in the pharmacist that was having those issues and experiencing that, but you're not the pick, that doesn't help you because you're still having the problems. So, another question here: does IPHA hold a stance on the antitrust involved with CVS's ownership of Caremark and Aetna? Is there anything IPHA can do about this? Yes, we do have a stance on it. We don't agree with it. That's been a long-standing stance. I'll try not to get too much onto my PBM soapbox here, but it is something that we continue to advocate for. And I just want to make sure that those who are on the call, you may not be aware that the FTC is looking at this issue about PBMs and how their business practices are impacting patients and impacting the industry. And so, and they've even went as far, they haven't released a report yet. But what was interesting is very recently, the FTC pulled back all of their previous statements they had made about previous mergers. And that's usually not a good sign for those that are being investigated. So we'll see what happens. I know that there are some bills going through Congress, but we know Congress can be very slower than molasses in trying to get policy passed, looking at the PBM issue. But it is something that we continue to advocate for from an association point of view on a state and a federal level. So thank you very much for that question. Is there a pathway to holding these large pharmacies accountable for the inevitable errors that occur in poor working conditions? And to that, again, I would say this is where the complaint process is key. What you're experiencing, if it is in a violation of what has been stated in the act, needs to be complained about. The department needs to know so that they can look at, because there's 27,000, excuse me, 2,700 pharmacies in the state. And again, 5 inspectors. So that takes, and one of them is the chief inspector who, you know, yes, he gets out and investigates, but he's more locked in with administrating the issues and the cases going through with the council. So we need more inspectors so the chief can get more people out to help address these issues and making sure that change occurs through the Board of Pharmacy. When will pharmacists get reimbursed for services? Someone's really trying to get me to get on my soapbox issues tonight. That is issues that we are also looking at as well through the association, working with other stakeholders. And I'm really glad that we have representatives from, I know people that at least signed up. I'm not sure exactly who's all on at this moment, but I know, you know, those of our friends and colleagues at the State Medical Society, the Illinois Retail Merchants Association, the Illinois Hospital Association, and the Illinois Council of Health System Pharmacists, who's a direct partner with us in our legislative day efforts. We are continuing to work on this issue because, as you know, over the years, we've gotten more law changes to happen about services that we can provide our patients. Now the harder argument of having to go through the process is that now that we're able to bill as a medical provider is getting the process through. So pharmacists, and I said that correctly, pharmacists, not the pharmacy, that the pharmacists will be able to bill for those services. Yes, some of you may work in larger corporations where you may be doing group billing, but that's your labor that's going into that, and that's your part of that money should be coming back to you. So that is something that we continue to advocate for and work on through all avenues. And we're glad to see that we're starting to get a little momentum of getting some of the bigger players to the table on the insurance side so we could start processing that, because that paradigm shift is something that's not going to happen very quickly. And it is something that has, if we want to say some of the stresses and the hard work we had to put through COVID actually showed the value, and our legislators and regulators saw what pharmacists were able to do, and it's made the arguments of making it where we can become paid providers more of an attainable goal. It's no longer a fantasy, it's a reality. And so now we just got to get the processes in place so we can help get you signed up and get you where you can document so you can get paid for those services. And again, help alleviate a lot of issues, because we know, as we know, that a lot of the reimbursement issues is based off an outdated model. The dispensing only model is outdated. And we have to be able to bring in and expand services to help make sure that the practices are sustainable so you can have properly supported teams as well. Next question is, how are we supposed to add prescribing birth control to our workload? Feels like that we are a dumping ground of healthcare. It would be like if a cardiologist was also supposed to specialize in OB-GYN, oncology, etc. It is too much. And that's one that goes in extension of what I just talked about. We want to make sure that you're able to provide these counselings and be able to get paid for them. And right now they're cash basis, but you can also right now provide the services for contraception and HIV PrEP and PEP through Medicaid. Illinois Medicaid is a recognized provider of that. So you can start providing those. And again, these require practice design changes. You're not going to be able to do these more advanced services where you're going to need to spend one-on-one private time with a patient for sometimes 15 minutes to an hour. You're going to have, and the corporations and other pharmacy designs will have to change. If they continue to try to do it in the existing model, everyone will fail, and our patients are going to be the one feeling that failure because they're going to get inadequate care and inadequate access. And so we have to make sure we have changes to that. Somebody had stated they saw a comment in a listserv that stated that some refills for mail orders should be for 1 year, and that would decrease the work for pharmacy staff. Is that an option that can be investigated? I'm really glad that somebody brought this up. This is something that I've continued to discuss with our board of directors, is that I find it the insanity that as healthcare providers, pharmacists are the only healthcare provider that sees their patients sometimes every month, if not more times, multiple times every month. No other healthcare provider has that. In extension, no other healthcare provider allows the patient to decide when they come see them. And that's something that we need to take a look at. We need to take a look at some really changed models of telling the patient when they're coming to the pharmacy and looking at refill changes. Can we look at legislative changes to allow 90-day supplies and not let the PBMs decide that they're the only ones capable of doing a 90-day supply and send patients more and more medication than they asked for? And be able to allow pharmacists to open up our workloads by being able to do this. But at the same time, as medications have continued to increase in cost, bringing in a 90-day supply for some pharmacies is a financial hindrance. So we have to find a good balance, but we have to at least open up the opportunities for pharmacies to be able to look at some of these newer appointment-based models and other systems to allow for you to manage the workload and not allow our patients to dictate the level of our workload. What are we doing in regards to changing the culture of pharmacy and how pharmacists are being treated? Pharmacists should have the same respect from providers and patients as doctors and other healthcare providers do. We have a doctorate in pharmacy. Why are we not calling ourselves doctors? I think if any of you have earned the degree of PharmD, you should be calling yourself a doctor, and proudly so. How can we get everyone to see the value and call themselves doctors? And I think that's when one thing I would highly recommend, I've noticed this whenever I go around to pharmacies in the state, pharmacists should not be having just their first name on their tag. It should say doctor, your last name. if you want to have first names for your technicians and your students, that's fine. But when the patient can recognize the pharmacist, and I know a lot of times that you hear this from patients, they don't recognize who the pharmacist is because everybody's in similar attire. Well, they'll know who the pharmacist is when it says doctor. And I know that there's been cases, particularly in California and others, where there have been cases for against other healthcare providers who have a doctor designation based off their education and proven experience that have had punishment for that. But that's not illegal in Illinois, and it needs to be highly encouraged. Bob, before I come back to you, Julie had raised her hand and she hasn't talked yet, and then I'll come back to you. Go ahead, Julie. Julie, you'll have to unmute on your side to be able to use your microphone. There you go.
Thank you. I just wanted to say I'm a pharmacist for CVS, and many years ago, the doctor title was removed from our name tags to not appear too intimidating to our patients.
That's good to know that. Thank you.
Mom, is that it?
Okay, Bob, go ahead.
Garth, when I started out, and probably you too, we were called doctors, even though we weren't doctors.
Mhm.
And as soon as the PharmDs came and got a doctorate degree, they're all like, "Oh, no, don't call me doctor. Just, go ahead." And I think some of it was from going through at the hospital where they didn't want to make any mistakes, like have somebody say something thinking that it's a doctor giving an order when it was a pharmacist giving an order. So I think that mushed things up a little bit. But right now, if you're not calling yourself a doctor, when you're a doctor or referring to have your technicians refer to you as doctor, that's a big mistake. And you should answer the phone as doctor.
Right. I agree with you, Bob, and thank you very much for pointing that out. And I think in health systems, there were issues with that. But I think in most of us, as we encounter in the health system environment, I know we've talked mostly about community, so I don't want that to be let people know that this is the only place where we know where there's workplace issues. I know that's also in health system and in long-term care. So if anyone wants to make comments on health system and long-term care, please raise your hand. I'll be glad to unmute you. But I know that in most healthcare systems, I've noticed now that it says in big bold letters, usually color-coded letters, what that person that you're talking to, what their position is, whether it's a pharmacist or a nurse practitioner or a PA. So if they have the recognition and the earned education of doctor, they should be allowed to use it. I mean, doctor is not reserved just for the medical profession. That's why they're called physicians, not doctors. They're physicians. So going back to comments, we have one here. I agree with the 12-hour shifts. There is an evidence in the literature about the impact on health and well-being as well as patient safety issues. Thank you for that comment. Is there a portal that allows us to file a complaint on telepharmacy and patient safety if we notice increased patient harm in practice? That again would be the department's file a complaint form where you can file that information. Another comment, is it possible to get legislation in place that states you can't work alone? There's always ways of being able to look at legislation and have that discussed in or regulations to take a look at that as well. Pharmacist has a determination of professional judgment. I 100% agree with that. And I don't think we utilize our professional judgment enough. And we have some newer language in the Practice Act that helps provide some additional protections, primarily when it's looking at not only just women's health, but usually, activities. It was language that was to protect Illinois healthcare providers from being unnecessarily disciplinary actions or fines from states where they didn't care for healthcare practices are allowed in the state around women's health. But I think it opens up for ensuring and protecting pharmacists' professional and clinical judgment. And I think there's maybe some ways that we can try to look at enhancing that as well. how is the pharmacy running effectively when pharmacists are outside of the pharmacy giving shots and everything inside is still under our name? And how can counseling even occur effectively if we are not physically in the pharmacy? And so there's some good questions there. And again, I think that has to go back to policies and procedures and making sure you have proper workflow and management on that. Um, I've definitely seen some best practices that can handle those type of issues, especially with the telepharmacy. There's the requirement for audio and visual counseling, and they're done very effectively. But we'll be glad to, if that individual wants to contact later, I can help discuss that more in detail. Oh, sorry, someone's raised their hand here. Carl, go right ahead.
Hi. So we talked a little bit earlier. I guess I was logged in under the wrong profile, but
That's okay.
but okay. So I was just wondering if IPHA would be doing anything to prevent possible retaliation from these retail chains, because I know, as you see, a lot of people are wanting to be anonymous on these
Right.
on the questions they ask and everything. Retaliation is a big deal. We're all extremely scared of it. I know several people that have been retaliated against in the past. Um, yeah, just I don't know if there's any.
No, you bring up a really good question. It's maybe something that we do need to revisit because we do have, when that was one of the areas that we were asked to look at as part of the Collaborative Pharmaceutical Task Force was retaliation. And one of the ways that we looked at that is that did we need to add any whistleblower protections into the Pharmacy Practice Act? And we found that pharmacists are covered under the Whistleblower Act, but there are also you're also protected from retaliation under Illinois law as well. So again, if you're retaliated against, I would definitely consider filing a complaint and actually seeking counsel. But that may be something that we do need to look at. So thank you for bringing that up so we can investigate that further.
Thank you.
I'm making a quick note on that real quick. Then we'll get back to questions. What is the feasibility of pharmacist overlap in future years when there are severe pharmacist shortages? I think that's something that's a very good question. And again, it gets to what we can put into the act. And again, we need to make sure that we're trying to develop best practices because the Pharmacy Practice Act has to encompass all pharmacy practices. And it gets to be an increased challenge of trying to address specifics, especially and this is where labor gets to be an interesting challenge of trying to address all practice settings and with that. But I think specifically when we're looking at shortages or even public health emergencies, we need to make sure that there's proper staffing, which can be a challenge whenever you may have the pharmacy team that could be impacted by the emergency as well. Why hasn't there been any action towards checking out union representation to help remedy these issues? There are two established unions in Illinois and have been for a significant number of decades, and both in the Chicago area. And so a lot of the issues when it comes to public policy, of course, are advocated not only by the Illinois Pharmacists Association, Illinois Council of Health System Pharmacists, but other organizations, including the retail merchants as well, of advocating on overall health policy and representation on those issues. Let's see here. Great comments. Thank you, everyone, for these. How do students or prospective pharmacists, student pharmacists, and other pharmacists advocate for themselves actively other than reporting these experiences? Should we leave the pharmacy, etc.? And how to balance patient safety while advocating for ourselves? And it's a very great question. One, making sure that you are filling out complaints, as I said, because that shows action. And if we continue to hear more stories that people are reporting and they're not being acted on by the department, that's something we will definitely be advocating and having hard discussions with the department about. But in addition, you can talk to your senator and your representative about these issues as well. That helps support us when we go and talk to those in the General Assembly about possible legislative alternatives. But also being, members of associations like IPHA, that helps us be able to help coalesce, and another organization to be able to help coalesce those voices. Like, our positions are based from our membership, and it goes through our policy process, and it gives the exact direction of what our board and myself and our other staff and how we address these issues. And so advocacy has multiple levels and multiple avenues, and that isn't just a pharmacist's responsibility, even though it's in our oath to be a responsibility. It's also a responsibility of our technicians and our students. And also, one of the best ways of helping make sure you get a voice to your issues is asking your patients to help advocate for you. Believe me, you start getting number of customer complaints about how pharmacies are designed and how they're being operated to the corporate businesses, they should be taken very seriously. I know they were whenever I was in a position of supervision. A customer call was an extremely important avenue that had to be addressed, and made us sometimes had to take a look at our own policies. And I encourage those of you who are in positions of influence to be able to be, hopefully if you're not listening to your employees, start. Secondly, be listening to your patients, because if they're not telling you how their experience and what the experiences are, how they're impacting them, they're doing it by leaving your practices, and that should help tell you something as well. Someone put in here from the Illinois Department of Labor, does this not apply for pharmacies that employees must be permitted to take a meal break for every 7.5 hours worked, no later than 5 hours after the start of the shift? An additional 20-minute break will be permitted if working a 12-hour shift. That's some language that is in the Department of Labor, and it's a little different than what's in the Pharmacy Practice Act, but it is stated in there. And actually, bear with me a second, and I can pull, well, I'll state what the language is in the act here real quick. And if anyone wants to come on to talk real quick while I'm looking that up, that would be very great, so we don't have dead air. That's all right. I'm right at the language. So in the Practice Act, in section 15.1, specifically in B, it states a pharmacist. And one of the things I want to pull back real quick. When you look at section 15.1, there are parts of 15.1 that say pharmacist, student pharmacist, and pharmacy technician. And there are a majority of this parts of it where it talks about just the pharmacist. And the reason why there's that this distinction is when we were, as part of the Collaborative Pharmaceutical Task Force, when we worked on this issue, we asked the Illinois Department of Labor to provide us recommendations and examine who was and wasn't protected under the current act. Because one of the reasons why pharmacists have to be added in a lot of these states and for these type of statutes is that we're exempt under federal labor laws for a lot of protections for labor, because we're considered essential to public health. And I know that's an oxymoron, because we're not recognized as federal providers of medical care to be able to bill and get paid, but we're forced on our labor without protections. But anyway, in section 15.1, it says in part B, pharmacists who work 6 continuous hours or longer per day shall be allowed to take at minimum one 30-minute uninterrupted meal break and one 15-minute break during that 6-hour period. If such pharmacist is required to work 12 continuous hours per day at a minimum, he or she qualifies for an additional 15-minute break. A pharmacist who is entitled to take such breaks shall not be required to work more than 5 continuous hours, excluding a 15-minute break, before being given the opportunity to take a 30-minute uninterrupted meal break. If the pharmacy has a private break room available, or if there is a private break room in the establishment, or business in that pharmacy is located, a pharmacist who is entitled to breaks must be given access to that break room, private break room, and allowed to spend his or her break time in that room. So I did want to make sure that we did read that language through, and if anyone needs a copy of that or any information, please contact me after this, and we can help provide that for you. Could we ask for changes to technician requirements to pass the certification exam within 2 years? Oftentimes, once it gets close to that deadline, technicians will either quit because they do not want to take the exam, or they do take it and fail and then are unable to work anymore past their 2-year employment anniversary. Excuse me. This causes great deals of stress in constantly training new individuals. Also, this exam is so broad that many techs are being tested on subjects that they know nothing about. This is a good comment, and I appreciate it. It is something that, you know, we continue to push for better technicians. One of the reasons we also have workplace and workforce issues is we don't have properly trained and educated and supported technicians. And we need to change that. And sometimes we've had to force that. That's one of the reasons we were one of the first states to require the certification exam. And now we've gone even further, that if a technician wants to become certified, starting January 1st of next year, they have to complete an ASHP, ACPE accredited technician program, or they have to complete at least 500 hours of training in the designated areas of the Act, which is already something that they're required to be trained on within the first 6 months. And so it is something that we need to maybe look at timeframes, but we need to make sure that we're pushing the workforce for technicians to be stronger, because stronger technicians will allow you to be able to do more and take those pressures off of you. But I agree with you. If you have a revolving door, yes, you're in that continued hell of training. And that is something that needs to be addressed. Looks like we got someone who's wanting to provide comment. Jafar, go ahead.
Hi, I'm a pharmacist at one of the corporate chains, and one of the things that is very clearly, to me at least, in Illinois law is we have a lot of protections, especially around things like quotas for certain things that we have to do by a certain amount of time. I believe there's a statute that gives us protection against that. However, a lot of the chains measure specifically how quickly we fill prescriptions, whether or not all the prescriptions are filled at a certain time, how many vaccinations we're doing, and all these things are measured and graded and scored, and bonuses are given based off of these things. I have a hard time seeing how that is within the legal requirements of not having these quotas in place. I don't know if that's something that IPHA has any position on or has talked to the board about at all.
Well, it's something
the other.
Go ahead. Go ahead. Sorry.
Yeah, no, I'm sorry. One more thing I wanted to. No, I'm sorry. You can go ahead and answer that first. I do have a second question as well.
Yeah, I'll answer that very quickly. Yes, we do have a position on that. That we definitely believe that metrics should not be used in a hindering way of allowing you to provide a safe workforce and environment for not only your team but your patients. So, and it is in. And I know metrics can be a loose definition sometimes, and those can be reworded in ways that they can still provide those type of unfortunate situations. So it is something that it sounds like, and this is something that we've been talking about since before this call here tonight, that it does sound like it's something that we may have to readdress and possibly put in a definition for. So thank you very much for that comment. Go ahead with your second comment.
The second thing is that it seems like we have a lot of great statutes in place in Illinois. I'm licensed in multiple states, and I was very impressed with the different protections we have as pharmacists in Illinois. But it does not seem like there's a clear and easy way to make a complaint about a company practice. So there is a way to complain about specific pharmacies, and as a pharmacist, you don't necessarily want to complain about your own pharmacy about a practice, because then you're sort of you're putting it on your own head. But it doesn't seem to be a clear form that, hey, these company practices, I believe, are a violation of the statute. There isn't a clear way to do that. So if I wanted to make that sort of complaint to the state board, I don't think there's a pathway for that. I do think that the board should be asked to open up a form when there are specific things like, let's say, specific metrics or specific staffing formulas or specific things that you as a pharmacist believe are hindering your ability to provide the correct amount of oversight to your staff and for your patients. there needs to be an easy form for you to fill out to say, hey, this is a form that you can go. And we're not making a complaint at a specific pharmacy, but more about a corporate practice.
Thank you for that. And I think that's a great idea and something we'll definitely ask the board to consider.
All right, thank you.
Let's see here. Another comment or question was the last time something like this happened, the state board initiated mandatory counseling. This didn't work if we were understaffed. How can we prevent this from happening again? That's an interesting that you brought that up. Whenever there was back in 2016, whenever there was that initial series of articles looking at, it's primarily in Chicago, looking at pharmacists not counselor catching drug interactions. The governor's office at the time reacted with that there will be a counseling, and there was no discussion on it. There will be a counseling mandate. And so that is something that, you know, I think it's something that needs to occur anyway. And again, we have to be making sure that there's time in the workflow in it to be able to talk to our patients. And again, if you're not in a workflow model that allows you to talk with your patients, that's already a violation. And again, one of the things that we even put in as an additional comment whenever this went through, we specifically sent the department a question about whether pharmacists can charge for counseling as well. And the department at the time, and we let it not be known to our membership that there's nothing, the department said there's nothing prohibiting pharmacists from charging for counseling. And again, you're leaving money on the table that would help support additional revenue coming in to support increased staff. And I think that's something that we have to change. We one of the biggest issues with our profession is that we are afraid to ask for payment. And that helps, then that directly leads to a lot of this understaffing as well, because we're not properly bringing in revenue to support what the workforces that we need to be utilizing. Great comment. What are goals and metrics chasing? There seems to be driving issues in the workplace. Yeah, we've talked about that as well. And again, I think we maybe need to look at a definition on a metric. Oh, we got Brittany. Go right ahead.
Hi, Garth. I just wanted to go back to the technician training for a second.
Yeah, go ahead.
I thought the individual who brought up the time period, I just wanted to share that most boards of pharmacy, well, maybe not even most, many boards of pharmacy, to be more accurate, actually require training programs be completed within the first 6 months of initial hire. So one of the questions that I wanted to clarify with you, I was actually recently on our Pharmacy Act and rules this week looking for Illinois with the upcoming changes that are going to be happening. And our language states by the second renewal. So in theory, with it being a once a year renewal period for the technicians, they would have 24 months. But how does that work for, let's say, a technician who applies for the registration, let's say in December, and then the renewal period is in March? Does the board typically, or IDFPR, generally extend that first initial license expiration? Or is that something we might need to look at to make sure that our language is clear that it should be 24 months?
It's something I think we need to bring a clarification for, because you are exactly correct. And it is something that we've discussed with the board and brought to their attention on a number of occasions, that you could actually be a technician for 13 months, but based on when you applied and got your license, you could have 13 months or less, well, 13 months at the minimum of having to be able to pass and pass the PTCB exam or NHA exam, depending which one you choose.
Yeah, I think that would be helpful. Thank you.
I agree. No problem. There was a comment in here. While the counseling requirements are great in that they make us spend valuable time with our patients, there should be some modifications, because this is incredibly time-consuming part of our job. Things like dosage change in provider could easily be communicated by a technician instead of a pharmacist. Well, one, there are very definite issues that are stipulated in the act about communication to a patient. Things like a dosage chain is absolutely a pharmacist job because that's talking about changes of the medication. If there's something about a change of provider or something that is demographic information or non-medication related information, yeah, I could see where that can be communicated by a technician, but anything involving the medication itself needs to be done by the healthcare provider. Would appointment-driven pharmacy practice help with professional well-being? I kind of addressed that earlier in one of the comments. Thank you for someone bringing that up. Hospitals, outpatient facilities, etc., have all figured out a way to charge patients insurance for every service they provide. There is literally a billing code for everything. Why hasn't there been more progress with pharmacists getting paid for critical services we provide, mandatory counseling for all new prescriptions in Illinois, etc.? There should be a way to bill for that service. This would add so much more to the bottom line. Sorry, I got on my soapbox before I saw this. Versus literally one trick pony to tackle all that. So it's multifaceted. And a lot of it is we're not recognized as medical providers and being able to provide that. And we have to get pharmacists individually credentialed with insurances. And that's something that we'll have to go through the process of, is that either through as a group model that your corporation will file with each individual, and then you will work, you provide those services as a group medical provider, or each individual pharmacist will also be or could be an individual medical provider of those services. So that, and I think, if there's not a billing code for it, there's always a method that works, and that's called cash. So don't be afraid to do that. And I know I got on reimbursement. I knew this hand would come up, so I'm going to allow Starlin to chime in here. Go ahead.
So within a health system, everything is a bundled payment in a DRG code if Medicare, or a DRG code in a contract with an insurance company on a bundled payment. So while you're coding within the inpatient facility, it's all going in. So you charge $2.50 for an aspirin and it costs you a penny. The rest of that goes to cover the dispensing of that, for example. In a hospital-owned outpatient facility, you can bill facility as an outpatient facility through the ownership of the hospital. And yes, there are ICD-10 codes and CPT codes that generate that. If you're embedded in a physician practice, if the physician practice is owned by the hospital, they bundle that payment into those codings. And if it's an independent physician that you're billing independently through that physician, you are billing incident 2. So in the pharmacy outpatient world that is not owned by or has an overlord that is billing in a hospital facility, a health system, or a physician group, we are not completely recognized. You're recognized as a pharmacy to bill for diabetes and diabetes prevention. In Medicaid, you can bill for hormonal contraception and HIV, PEP and PrEP, and also for diabetes and DPP, but we're getting there state by state. We are working feverishly to get commercial insurance to recognize us as providing these services that we have expanded our scope of practice for in the state of Illinois, and each state has to go after their commercial insurances because each state is different because of our everybody has different laws grouping in their insurance programs. So yes, there are a lot of billings. Yes, there's a lot of CPT codes. Yes, we're tracking all this, but there are many all your health system organizations, all your outpatient organizations that have embedded pharmacists in it, the FQHCs that have embedded pharmacists in it, and our independent pharmacies and our grocery store pharmacies, and even some of our I mean, CVS has a big program going on with their vertical integration using some of those pharmacy services and nurse practitioner service. So all this is all going, all these wheels are turning all at the same time. And we're hoping it all rolls out with all of us landing on the same side of the coin so that we can all have those expanded services. So we're working on it.
All right. Thank you, Starlin. And it's a national effort too. This is a coordinated effort that's taken many years, and a lot of the pieces are finally starting to move in the right direction. So I want to give kudos to Starlin for all of her work on a state and a national level with helping try to drag us along by the earlobes as we try to get into this new rights and responsibilities. So thank you.
You're welcome.
Carl, I'm not sure if this is you again or if Fazia has logged in.
I'm here. Can you
All
hear
right.
me?
Go
I'm
ahead.
here. It's Fozia. Officially me now.
All right.
Thanks for hosting this. I really appreciate it. I'm a 20-year vet and I love retail pharmacy. I wanted to piggyback off of your question about the state board having only 5 auditors or so.
Mhm.
So when I was audited by the state board multiple times, I was fined and disciplined and for all reasons that were beyond my control, threatened of being disciplined for reasons that were beyond my control, that were because I didn't have staffing. So then when I asked the question about the patient counseling being implemented by now I know you said it was the governor coming. So I feel like when we're having this conversation and it's this continual narrative that the state board needs to get involved, but in effect, when they get involved, I feel like the opposite is happening. And so how can we prevent this situation where our ultimate goal is to make sure that we have patient care at the forefront, pharmacist care, technician care, where we're all supported in a good way? It's like, I just feel like this is what we just keep talking about. But when we're trying to get the state board involved, my question is, where does this go from here in making sure that the right laws and things are put in the right place where they should be put in?
Right. Well, and that's where we've got to hold the Board of Pharmacy accountable too. And so I'm glad you brought up this point. And sometimes it means that we have to advocate for legislative and regulatory changes, which we did when, four years ago when we put in the lunches and breaks and the violation sections into the act and encouraging the whistleblower protections as well. But there may be additional ways that we need to be looking at this. And so, but we gotta, if we're not seeing the board do things based on what they're doing now, then we need to be putting in language to help provide them and push them and require them to be looking at things in a different manner that provides the coverage that our patients need and patients deserve.
Exactly. Yeah, that's what I really hope. I hope so.
Yep. Thank you.
Thank you.
I know we're getting close to the 2-hour mark, but I will be on here as long as people want to provide their opinion. So I do want to continue to go through some of the questions that have been submitted. Let's see, that looks like more of a comment to another question we had earlier. Yeah, someone's talking about the unnecessary that we have a lot of surveys. So it gets back to we have to have data. I want to for us to be able to show information to the board and to legislators and the governor's office and other impact stakeholders. We got to have data. One of the things that I'll use as a quick aside as an example is the recent Illinois Auditor General's report that showed that the PBMs that are part of the Medicaid managed care program, they've stolen over 2 years, $200 million of funds that were directly to go to pharmacies. So that's $200 million right there in 2 years that could have provided you more staffing. But we provided them with anecdotal evidence of that for over a significant number of years, 5, 6, almost the entire, I think 8 years now that that program's been in existence. But they only really now are believing it because their own report has shown that. So we need the data. So I know it takes a little bit of time to go through that, but I really encourage you to fill those out. So thank you very much for helping us out. Badria, go ahead.
And I'm just gonna echo that real quick, Garth, if I can. One of the comments that I actually received as I was working on advertising the town hall and creating the survey was, those who work on the front lines know what's going on within pharmacies, and if you worked on the front lines, you would as well. And my response to that is all of us within the association are acutely aware of the things that are going on within the pharmacies, right? Many of us are still practicing pharmacists that work with patients every day, that work with insurances every day, and are acutely aware of the situation at hand. But it's very different when you go into a room with the Board of Pharmacy and tell them, I know this is going on, versus here is a survey that was filled out by 200, 500, 1,000 pharmacists that says these are the issues that we are seeing. And it's a survey that we actually have access to. I understand that there are other surveys that are available to be filled out, including the Power Portal, including the IPhA Wellbeing Index. But those aren't surveys that we actually have access to all of the results for, whereas this survey that we've created and the town halls that IPhA is holding, we will have access to this data, and we will be able to actually use it to highlight some of the issues that everyone is seeing in practice for the board.
Right. In addition to that, I know some of the questions, and I really want to say thank you to Badria for, who's our current IPhA vice president. She helped us with putting together the workplace condition survey that we've released tonight. And some of that we've had to do some last minute changes because the Nevada Board of Pharmacy has actually released their own survey, and we were looking at their tool, and that actually modified a number of our questions. So the data is important, and I know it takes time, but it does help. Again with Carl, go ahead.
Hi. So along with the data is great. It's always great. One of those things that I think about is, and I know this is probably impossible, but like over the last 10 years, it would be really great if we could see like basically a technician hour budget, pharmacist hour budget over time versus the prescription volume of a certain pharmacy. I know it's completely impossible, but
that would be great data.
Yeah, wouldn't it?
Yes.
Just because like that's one of the things that I think plagues most of us, is just thinking about like how years ago, wow, we used to have so many more people and we had such a lower prescription volume. I know that in today's world, pharmacies are pushing more towards vaccinations because it's a better margin for them. But like, vaccinations are one thing. You can have somebody go do all the vaccinations all day long, but you still got to have enough people to fill all the prescriptions safely and do all the counseling and answer all the phone calls and everything like that. I wish there was some way to track that. Obviously there's not, but that would be cool. And if there would be a way to do that from now, going forward from now, that would be pretty awesome too. But
yeah, it'd be interesting to see that data. Just then you're getting to business data, and that always gets to be hard to get. I'm sure there's been some studies that have looked at that in a short-term time frame. But one piece of data I know I can share, and that's data that IPhA worked with Southern Illinois University Edwardsville School of Pharmacy. on a student project was looking at pharmacy deserts. And we know that from 2009 to 2019, over 800 pharmacies closed in Illinois. So that doesn't help the workload when we're losing pharmacies.
Yeah, no, that's bad,
So,
especially if they're independent pharmacies.
right.
Yeah.
And these were looking at pharmacies of all levels, but yeah, you're exactly right. You know, when we're losing pharmacies, that puts the workload on somebody else. So yeah,
Yep.
it's not the data that you were looking at, but that is some data that we do know. So
Yeah.
so thank you.
All right, thank you.
Is there a reason why Illinois doesn't have a law regarding narcotic dispensing only by pharmacists? I don't know if we've ever really considered it. I can think of a couple of ways that that could be a hindrance to telepharmacies or other practices, but again, something we can always have a discussion about. Missouri requires pharmacy supervisors to be a pharmacist. Do you know if this has helped workplace safety and satisfaction? I do not know, but I will talk to my counterpart about Ron Fitzwater with Missouri Pharmacy Association about that, and see what experience they're having with that, and if that's helped. Because I think there has been some changes with some practices of understanding your environment. It's hard to understand a pharmacy environment if you're not a pharmacist, so that can be a challenge. Another comment in here was Walgreens recently established a notice that overtime by technicians would result in a write-up, but they still have some pharmacists who are getting BPay. I'm assuming that means back pay for working at other stores. What can we do about technicians? We are willing to work overtime, but cannot due to company policies. And again, you know, if depending on where you are located in the state, again, if you're part of the union, that is a way of talking about that. But you know, there's also again that there's ways of advocating for those changes as well with your supervisor, and definitely, you know, look at a complaint. Policies like that could be considered a hindrance. So again, this is why the board's got to start to get involved to start making these decisions, because some of those changes won't correct behavior if we don't have complaints for them to go through the official process. Can you speak a little bit about whether fines are both individuals and businesses for operating outside business hours have been explored? Business hours would not include break times, which could be posted to expectations set for everyone. This seems like it could align for a sentence for both pharmacists and businesses. It wouldn't take care of tech help, but this is getting to a lot of the issues that I know that some pharmacists are being required sometimes to come in before their shift, or before they're open. And the one thing that I would highly caution with that, there's a 12-hour limit in this state. If you're coming in an hour and still working 12 hours open, that's working 13 hours and that's in violation. And that's something that needs to be brought forward in a complaint. But I think there has to be an exam of looking at that. And I know some businesses look at, you know, pharmacists, some pharmacies designs have pharmacy personnel, pharmacists in particular, as salaried. It doesn't matter. It's 12. And there needs to be ways of looking at compensating that if it's outside that 12. Can a store remain open if they don't have a PIC for that location? Shouldn't they be getting fined for this? There's actually 30 days in the act for them to be for someone with a pharmacist in charge changes, for them to notify the department of that change and when the new pharmacist in charge is in place. So but they really should not be operating without one. And if it's especially if it's outside that 30 days, it's something that the inspector should be taking a look at. Would creating a statewide patient safety organization help with these issues pertaining to patient safety? It could be something that could be a model to take a look at. I believe that's something that California may have instituted with their current practice. We'll have to take a look at that. I know from our point of view, from the association, we're against mandatory error reporting, because at least when the policy was done, the patient safety organizations didn't exist, and a lot of it is there's a lot of data and the show that mandatory reporting actually makes reporting go underground. But a lot of those reports were done whenever patient safety organizations had not existed yet. So that kind of changes things a little bit. So maybe something to explore. Why are patients being forced to go to a particular pharmacy because of their insurance? If we protect patients' choice, and if they are being made to go to a pharmacy that's shorthanded, it's not fair to the patient. Should patients' rights to choose a pharmacy be their right? Patient safety is a priority, so it is a patient's choice. And I agree with that. And that's why we have any willing provider language in the state, but that provides to contracting. It doesn't talk about any willing, and the patient has a freedom of choice, but somehow that doesn't apply to their insurance design. Somehow that shows that the patient's made a decision and is complicit with the decision of being limited. And I think that needs to be continued to be re-explored, because forcing patients to go to a pharmacy operations that aren't able to process the workload doesn't help anyone, and especially the patient. Off topic, but how do we feel about not being able to break insulin boxes? From my side, we have a decent homeless population. We help. When we can't break the box, we run the risk of patients losing the pins or not being able to properly store them. Also, it doesn't feel 100% ethical when day supplies are less accurate. Some of that's going to change with the audit language that's going to go into effect January 1 on contracts, that one, you can't break boxes. And I understand about patients losing pins, especially in some of the housing population or less housing population. But the manufacturers, in the way the FDA approves the boxes, they're to be dispensed as they are deployed to us. And actually breaking boxes breaks the approved labeling and packaging by the federal regulations. So there's ways I think that we should continue to work, especially in these communities, to try to work on that. So not to get too off topic, but I'd like to talk to that individual off this call to brainstorm about that a little bit more. I know metrics have been brought up, but is anyone at the board or committee looking to abolish them? We talked about how we may need to be looking at additional definitions for that. Thank you for that comment. Is the board of pharmacy prepared for their approach if what has happened in Canton, Ohio with CVS happens in Illinois? And I will have to take a look at what happened in Canton to be able to better answer that one. But if that person wants to unmute themselves, they can share that comment. But we'd be glad to provide that suggestion to the board to make sure that they're prepared for situations. The requirement put in place last year for opioids to counsel on every single fill has put a lot of stress on pharmacists and causes a lot of patients to be irate. Is this timeline being reevaluated? And this is something that I think we should be reevaluating with the General Assembly. This was something that was deployed by the General Assembly with not a lot of give of our opinion from pharmacy or medical on this. It was more of, you're going to do this, because to be honest, doctors aren't writing for naloxone enough, and pharmacists are not dispensing naloxone enough. And the General Assembly is still seeing the numbers tick up of people dying from overdoses. And so this was one way the General Assembly wanted to address the issue. I think there's better ways of looking at it, and it's something that, we can bring up additional remedies, but we'll have to have a remedy. It's not going to go away. We're still going to have to interact and talk with patients about naloxone, and we should be encouraging it with naloxone. But I think there may be some better ways of doing it than the current required legal method. After you report to the board the opinions, challenges of this town hall, what direction do you think the board will pursue, and when can we expect some workload relief? I don't want to speak for the Board of Pharmacy. I don't have any authority to speak on their behalf. I hope that they highly consider the data that they're looking at here and will consider remedies, because I know that, some may feel that the board doesn't have the authority to address workplace issues, and that's wrong. The board is there specifically to be protecting the public, and workplace issues are a patient safety hazard. And the board has 100% purview over this. Now, that's my opinion. But I hope they take this data seriously, because we're not going to become quiet on workplace issues. If the intent is to have this meeting so that it can be done and then they never have to hear about it again, they're sorely mistaken. I hope we get to see some actual challenges and some expedient action in taking a look at that, whether it's a legislative or regulatory action, or putting out better guidance from the department. The department and the board have ways of being able to provide guidance. And I think there may need to be some more of that coming forward. And I have to give a lot of credit to the new chief inspector. And if you're not aware, there is now a newsletter that comes out from the board that's oversaw by the chief inspector. So that's new. We haven't had that type of regular communication in a long while, and we've desperately needed it from the department, because I can expound on IPHA or my personal interpretation of the act, and we do, but we're not the board, and that's our opinion. And we need the board to be able to start putting down better guidance of how the act should be deployed, and we need to press that upon them. So thank you for that comment. Let's see here. One comment that I have is that it's one thing to count number of prescriptions, but but the complexity and sheer number of medications continues to increase. It's one thing to dispense medications for a prenatal vitamin, but it's another to fill 10 medications for a chronic kidney disease patient that also has diabetes and is a cancer survivor. So just counting the number of prescriptions is not really accurate, and the public should know this. I agree with that. Every patient is every patient. And some patients you can be done with them in a minute or two, and some patients you need 3 hours. And we need to be building better practice models to allow for that. While this might not seem related, I do believe it is relevant to the quality of rotations for students. Will we ever be paid for working at our rotation? Most of us don't ever gain experience as we give shots and fill prescriptions, especially in community rotations. Pharmacists are so busy trying to meet metrics, not their fault, that they just treat us like another tech. Working 8 hours a day for free while paying tuition just doesn't seem fair. I would refer that comment to the colleges, because that is part of your experiential education, that your tuition is putting you into those situations. Not sure about how that could work in a paid situation, but one thing I do agree with you is that we need to make sure that we have student pharmacists in quality rotations. And if they're just being used as another utilized technician, the colleges I do know go out and look at and do field reviews of sites, but they're also put into the position of making sure they have enough sites. So it's a damned if you do and a damned if you don't situation. But maybe this colleges should be a little bit better about saying you don't meet best practices and you're no longer a site. Money and the lack of it, making it into pharmacies is the root cause of this problem. Spend more on prescription medication than any other country in the world. Where is all the money going? Oh, we know the answer to that. It's in the PBM's pocket. Any thoughts of modifying the Pharmacy Practice Act to permit the conversion of dosage forms, such as changing capsules to tablets without the need to contact the office directly, as long as there are no significant therapeutic difference? This practice is already allowed in some other states. Yeah, the practice of adaptation is allowed in a lot of other states, and it's actually something that our IPHA Legislative and Regulatory Affairs Committee is considering, and hopefully if it may be even something that we're looking at for the spring session, depending on how all that starts to roll out. So it is something that is under at least active consideration from our association's point of view. When will the associate advocate for legislating additional tech pharmacy help with every new task they are asking for to perform? Again, try to make sure that we are advocating on every level, and it's just these things do take time. And I think we've made a lot of progress in the last couple of years, but as we all know, things can continue to be better because they're definitely not 100% golden. How can whistleblower pharmacists be protected in Illinois when it is an at-will state? There are situations in Illinois law that override at will, and that's if a pharmacist is being retaliated against, and other provisions that are in the Whistleblower Act. And that's why part of the task force, the initiatives that we did put in the Pharmacy Practice Act was just a line to let people know that there is a Whistleblower Act, and gives the citation for that. So again, if a pharmacist is being terminated for situations that would violate their protections, at will is no longer allowed. it's it's a violation then at that point. So again, legal counsel can help with that. Individuals who have felt retaliated against or are part of one of the few in Illinois, if you are in a union member, you are allowed to use your wine garden rights. It defines among the rights protected by Section 7 is the right of union represented employees upon request to have their union representative present during an interview that the employee reasonably believes could lead to discipline. So that's a good reminder for those that that have that afforded to them. Employers violate the NLRA if they proceed with an investigatory interview while refusing an employee's request or retaliate against them for making that request. Depending on the circumstances of each case, the board may order that employer cease and desist, post a remedial notice, require the employer to repeat the interview with a union member present, or rescind and remedy discipline resulting from the wine garden violation. So again, for those that have that option protection, thank you very much for providing that information. Someone's like, could we please have the CE links for techs and pharmacists? This is not a CE session. This is a completely informational advocacy session. So we did not want to limit it and confine it to meet CE requirements for this important session. If we have better technicians, then they need to be paid more than fast food employees. I agree. Yes, technicians are not going to have to be serious about a career in pharmacy in order to practice in Illinois. I hope DFPR puts the instruments in place to manage all these requirements. No changes will take place unless there needs to be support from the department. That's a very good comment. DFPR can hold technicians accountable for these requirements. Yes, that's specifically stated. When there's violations of the technician training, it's not only the pharmacist in charge and the pharmacy's responsibility. In the act, it specifically says that it's also the technician's responsibility. And so if you have a technician who waits until 1 month before their 2 years is up, that technician is not been within holding themselves accountable according to the act. And and if they get brought up on a violation, that information will not look good for them. So they need to hold themselves accountable. Along this line of conversation, is there anything that prohibits setting a minimum charge on prescriptions? I am not reading any more into that question. That's against antitrust, and I'm not talking about that. Pricing is a business to business decision. It is something that cannot be ever dictated by an association or any other conglomeration or combination thereof. Are we not losing good if not great pharmacy technicians who aren't made or able to pass the exam? Again, there's ways of being able to provide adequate training. Not to plug a service that I know that we provide, but also ICHP helps provide. But we offer access to Pharmacy Technician University, which is a training program that is built by the company behind Pharmacist Letter to help provide and position technicians to successfully pass that exam and to be a better and more qualified technician for your practice. Another mandated naloxone question. We just talked about that. How can we better utilize students for changes in the workplace? We have all these energized students who want to make changes as their future, the profession starting down 20, 30, 40 years of being in these practice settings. Would it be good for students to unionize? Should students be taking on bigger roles in practice? I think that a lot of practices are underutilizing student pharmacists. Remember, a student pharmacist can do primarily everything a pharmacist can do as long as you have a duly trained pharmacist that the student pharmacist is practicing those services and activities that a pharmacist can. And so student pharmacists, if you have them, make them do the counseling, have them do all the counseling with the patients, have them be vaccinating. Remember, if you're not utilizing your technicians to be administering immunizations, again, that's also shortfalling what you should be doing. Pharmacists should not be doing technical tasks. And those are things that we have to look at workforces. And I know there's some corporate policies about that, but we need to understand it's 2023 and times have changed. And we've got to help empower pharmacists to be able to be working on clinical tasks and let technicians doing technical tasks and let student pharmacists be doing all of those to help us, and it gives them great experience to be better pharmacists themselves. Let's see here. There was a national story about a pharmacist that fell ill while working in a retail pharmacy, but she was told she couldn't leave work, close the pharmacy until another pharmacist arrived. Is this legal? Again, I'm not going to talk on behalf of the department or the board, but I cannot understand any situation where the board or the department would ever punish a pharmacist who is in physical, mental health distress of closing a pharmacy. Would be the wrong decision to do. If you're in danger of your personal or mental health where it's incapacitating you because it's actually making you a danger to the public at that point, every minute you're there, you're more of a danger. The pharmacy should be closed. And I don't think any common sense of any board or any department would ever hold a pharmacist accountable for that. And if a corporation is that cold-hearted, they need to be re-examining themselves severely. Why are patients being forced to go to a particular pharmacy? Because, oh, I've already read that. Sorry about that. Is it possible that we've already talked about students on rotations? I think some of you were putting your questions in again, so thank you for that. At my previous pharmacy tech hours were not based on prescription volume, is based on labor percent. Again, there are a lot of models out there. I know I utilized a 10% rule of volume as to help guide my decisions on what I appropriated out to my pharmacies that I helped supervise. Did that mean that's what it always was? No, I had to look at each practice on its own, but it was my guidance. So there are definitely models out there to help provide for proper workflow management. Technician hours should be directly related to reimbursement. Pharmacy business used to be more profitable, and that was agreed. And that was when we didn't have. And this is where I know I've gotten on my soapbox a little bit tonight, and I tried not to, and I'm going to get back on it just for a little bit. This is where I think some of you that are, especially in some practice settings, this could be happening in some independent pharmacy practices too. So I'm not going to say it's just chain pharmacies. If you as a pharmacist and a pharmacy staff member don't have access to understanding what you're being paid and not being paid for a prescription, it doesn't provide you all the evidence to know that many of the prescriptions that you are filling every day are underwater. Your company's being paid below what it costs to bring it in. And then the PBMs, and this practice has been allowed for almost 30 plus years of providing a dispensing fee, which every pharmacy is allowed to be provided a dispensing fee. But dispensing fee is supposed to cover cost of dispensing, which means in Illinois, based off of surveys, should be close to $13 to $15 per prescription. And PBMs, Medicaid, and Medicare allow PBMs to reimburse pharmacies as in a range of as low as 25 cents or sometimes zero, or little as 50 cents to $1. Pennies compared to the cost. And then we wonder why some pharmacies are having troubles deciding whether they can stay open next week and meet payroll. And so, yes, technician hours, all that has to go into the calculation of making sure that a pharmacy is properly reimbursed. Thank you very much for that. And Rupesh, thank you. You're going to allow me to take a break from answering questions for a second. Go ahead. Rupesh, you may have to unmute on your phone. If you are on your phone, you may have to hit *6. Okay, I'll leave Rupesh's where he's unmuted or can be unmuted, and I'll continue with the questions. I would like to ask the Board of Pharmacy how one pharmacist can be responsible to counsel at 3 points of sale, give 50 vaccinations, and fill 400 scripts, answer the phone calls, do data entry, train technicians, do MTMs, and everything. And everyone knows this is going on. And I agree with you on this. Go ahead, Rupesh. Go ahead.
Yeah, can you hear me?
Yeah, go ahead.
Yeah, there are a lot of challenges we all are facing, and it's affecting us differently. But this is the opportunity for us to know that only if we get together and work together, regardless of our practice setting, we'll be able to fight some of these challenges. So we need to, and now is the time that we need to stay away from the word independent chain hospital.
Oh,
We are
you need to speak but more into the phone. You moved away from your mic.
So like in this event, we were able to get 200, 300, 400 people to register. We have 6, 7, 8,000 pharmacists in Illinois. We're our own thing. We need to figure out the system.
Rupesh, you're very muted wherever on your line right now. We can't hear you.
You see, this is the actual time for us to figure out a way to unite. And every time there's a challenge, we need to support each other. Time for uniting is now. Otherwise, we're going to be in trouble long term.
I agree
So
with you.
again, my
Rupesh.
request to everybody is, regardless of the challenge, we need to be together, all of us.
Thank you, Rupesh. And for those that may not know, Rupesh Manik is our current IPHA president. And I greatly appreciate his comments. So thank you. And so the question about the workload is definitely something that we will continue to bring up, especially about verifying and counseling at 3 different locations, especially with these remote issues going along. So thank you very much for that comment. Walgreens used to have KPIs of scripts per payroll hour visible to the pharmacist, but it's no longer accessible. That's interesting. Probably to try to get around metric being measured stipulations, but it's hard to know what you're being measured against on labor. So there needs to be discussion of workarounds on that. What's the best way for pharmacists to keep the momentum going? Advocate. This is, as Rupesh said, this is time to get together. This is definitely a critical time for our profession. And what are some immediate ways to get involved? We've talked about how to make sure you're providing data, providing the surveys. You being here tonight helps move things forward. I don't want anyone to ever tell you that not voicing your opinion, that voicing your opinion is not a good thing. I always want to make sure that you're heard and that your voice matters. And by helping make it louder, as a lot of our some of our members say, is get loud, and that's by being involved. And so I definitely help encourage you to keep this momentum up, keep coming together at these events, keep coming and advocating to the Board of Pharmacy, advocating, because remember, you can come to the Board of Pharmacy meetings. They're the second Tuesday of every odd month. And there's a location, and most of the time now they're having WebEx available. So you don't have to be in person, but you, as the public, is allowed to make comments. So you're allowed to talk to the board, and I would highly encourage that as well. We're just trying to help coalesce and help elevate and empower that voice by having discussions like tonight. B rate is B pay is the B rate pay, which is higher, which is better. Thank you. I thank you for providing that definition for me. Thank you. Do you think that there ever be a national board and not a state level board of regulation? No, not in the current design, because as part of the Federal Food and Drug Act, sorry, I won't go too much into my pharmacy law instructor methodology here, but federal law specifically gives the states the right to regulate medicine, pharmacy, and the other healthcare professions. So that's a state level. Now, NABP, the National Association of Boards of Pharmacy, does provide model act and regulations and other additional guidance and services to NABP. And I know NABP does look and consider and tries to advocate for ways for them to be encouraging on a state level, on a national level of advocating for these issues. And it's something that we continue to address and ask for NABP to get ever more involved. And I think that's something that can be done. So it's a good idea. I think NABP just needs to be more advocating. So that's something that can definitely be moved forward. So Carl, your hand raised, so go ahead and unmute. Oop, there you go.
Okay, there it is. Okay, so we talked to Shane Jereminski earlier.
Yes.
From California. So regarding unionization, he and a few other people across the country have built up this movement to unionize, as it's not just pharmacists, but pharmacy technicians and all pharmacy staff across the country. Pharmacyguild.org is the website, and you know, so far they've gotten a lot of attention, but you know, the only way that we can get more attention is if more people sign up for it. So it's nationwide. It's not just Illinois. Illinois is great. We love Illinois. I mean, we all live here, I think, most of us. But there's also other pharmacists across the country. And if we can get them all involved, that's great too.
Yeah. Thank you very much for providing that information. There was a comment of saying, don't forget to register for Illinois Pharmacy Legislative Day on March 5th of 2024. That is an event for those who may not be aware of Illinois Pharmacy Legislative Day. It's an annual event that is co-presented by IPHA and ICHP, the Illinois Council of Health System Pharmacists. And this is an event that we are glad to provide as an opportunity for pharmacists to be able, and technicians and students to be able to advocate directly to their senators and representatives. So if you've never attended, put March 5th on your calendar and come on down. A comment: I submitted threatening emails I received from my employer regarding MTM quotas and vaccine quotas to a state board inspector. They answered in 1 year that I had to submit specific situations. Seems like they don't want to do anything. Well, thank you for providing that comment, and we'll ask them to how they can better address some of these situations when they may not be specific in their case design. I'd like to see IPHA facilitate a platform for pharmacists across the state to communicate with each other regularly, could be anonymous. I'm glad you brought that up. It is something that we're taking a look at, trying to figure out how to better allow for communications as long as we stay within certain stipulations and, you know, staying away from antitrust issues and things like that. But I'll definitely look at, especially with the anonymous component of it too. We'll have to take a look at that. So I'm not opposed to it. We've been looking at some issues. Actually, we've been looking at Discord. And so there may be some additional ways for us to help facilitate communication. So thank you. Pharmacy school enrollment is going down because of wages, work conditions, etc. A lot of pharmacists are leaving the profession in droves. So as the future of the future, Board of Pharmacy needs to be aware of that. And I really appreciate that comment. And we had a great town hall that was done back in October by Dean Melissa Hogan and Dr. Singla from Roosevelt University. That talked about in relation to some of this issue, and it was presented at our District 4 meeting, and we presented it here. Still editing the video. Unfortunately, it's taken longer for me to edit that video to get it up, but we will have it up, and it is information that I think the board does need to be aware of, so I'll pass that along as well. Someone just wanted to add, I'm not saying that I think patient counseling should be removed. I think it's a wonderful idea in theory. Oh, that I need the support staff to accommodate all the measures. Yeah, I agree with that. Accreditation requirements do not allow for student payments while on rotations. Thank you, Dean Hogan, for putting this in there. I knew there had to be an ACPE issue with this. The issue of quality of rotations is a significant concern. And with the current workplace issues, particularly in community pharmacies, all students are encouraged to share concerns with their school's director of experiential education during the rotation and via end of rotation reviews. Thank you very much for that comment. Are you going to provide the information about the December 19th meeting? Because I'd like to go. Let me pull that up before we go any further. I do have that information, but I have to grab it out of my email here real quick. Hang on one second. Because it is December 19th at 10:30. I just want to make sure I get the room because it's a specific room that it's in the building that DFPR is in. Hang on one second. because the notice should be officially on the board's website, but I haven't looked to see if it's actually there at the moment. But let me shift my share to my browser here. So if you look here, the Board of Pharmacy will convene at 10:30 a.m. on December 19th in the Lincoln Video Conference Room on the 4th floor, and it's at 555 West Monroe in Chicago. And room 376 on the 3rd floor of 320 West Washington here in Springfield. 320 West Washington is the main building for Department of Financial and Professional Regulation in Springfield. So if you've ever had a license issue and had to come down here, that's where you went. The new building 555 West Monroe in Chicago is a new multi-department building that the state is utilizing up in Chicago. And we can help post this on our website after this meeting as well. Want to get through a couple of the final questions we have here. How can we hold abusive patients accountable? Is there any way that we can fire patients without being disciplined by your employers? Nothing in the act forces you to provide service to anyone. Pharmacists have the right to tell a patient to take a hike. And if they're being if they're committing harassment or threatening you, they can go take it somewhere else. Employers need to be looking at that and being protective and supporting their patients. Sorry, I'm definitely getting on a soapbox on this one. This is one where when I was in practice and definitely when I was still in the department on a day-to-day basis, anyone started getting out of line, I was the first person in front of them, moving my technicians and students out of the way, and definitely telling them, saying, well, how can I help you transferring your prescriptions because this behavior is no longer acceptable. They get like that, they're gone. But I agree, we got to look at policies to help address this, because especially after the pandemic, and I know most of you have seen this, patient behavior has gotten out of control. And I'm definitely open for suggestions because we're trying to look at what policy options there can be for this. Another comment, we need to get numbers so we're loud enough to be heard. Again, exactly. The more our voices go up, the better. We provide information on the board meeting. Where is the survey IPHA is taking to the board? If you look at up here on the screen, the QR code, it says workplace survey. It's on the right-hand side. We'll also be posting a link to it on our website. I just didn't get it up before the meeting tonight. Are pharmacies required to allow incoming calls? Okay, what's this again? Are pharmacies required to allow incoming calls for patients? Starting in January, some chain pharmacies will only allow patients to leave a voicemail, which will be converted for a transcript for the pharmacy team to review. There's nothing in the Pharmacy Practice Act that would require that type of communication. There is a requirement for a telephone in the pharmacy, but the spirit of the language doesn't go to direct contact. So that'll be interesting to see how that facilitates communication. I know that a lot of companies facilitate call centers or have in the past at other locations to help with facilitating communication. So that's interesting. So no, we don't have anything specifically in the act on that. I do want to be respectful of people's time. So like I said, the next steps are for us to, or we're developing workplace survey. Excuse me, I did this before yesterday. We have developed a workplace condition survey. This is the QR code for it again here by itself, and we'll be presenting that data to the Board of Pharmacy. I really, again, want to thank everyone that has been on this important meeting tonight, and a lot of you have stuck through with it. Over half of you. I'm still going through. We did receive some anonymous comments, and those are just as important, and I'll want to read those in here in a minute. But thank you again for attending this virtual town hall. You've exceeded my expectations significantly, and that just shows that we're doing the right thing of helping advocate for you and listening to you. And I really appreciate everyone, because I know it's not comfortable to talk about things, especially when you have employers who are not acting in the best interest of others. But make sure that if we are doing some additional in-person town halls in the run-up to the Board of Pharmacy. So, and we have limited attendance just due to space at these locations. The registration form, just so we can make sure we aren't running over, is on our website at IPHA.org. But December 8th, so this Friday, we'll be at Roosevelt University from 1 till 3. December 11th on Monday, we'll hold at IPHA headquarters from 6 to 8. But if you want to come in earlier in the day, I'll be there. And we'll be able to hold 40 people at that location, 120 at Roosevelt. And in the southern part of the state, on December 13th at Veterans Airport in Marion on Highway 13. From 6 till 8. And again, that room is limited to 120 attendees. So again, if you want to encourage any of your peers who have not had a chance to voice their opinion and their voice to make sure it's heard, please make sure that they attend. And if you need to want to come to any of these in person to have a further conversation, please feel free to come. I am going to go ahead and for our record, go ahead and read through some of the additional comments. And those of you can go ahead and stay on. If not, I really appreciate everyone's time. I am glad that we've exceeded our time and our initial thoughts on this. So thank you very much. We had a comment that said work conditions have never been worse. Workforce require more capital, but financial burdens makes the conditions even more worse, which we did discuss some of that earlier. Reimbursement from insurance companies is so low they can't afford enough help to hire, and reimbursement should be increased as much as being paid to big stores like Walgreens and CVS. So talking about some reimbursement parity. Patient safety should be of utmost priority. Pharmacy workplace needs to be addressed, and pharmacist workplace is getting worse. This is a lengthy one. Bear with me here. I respectfully submit that as a registered pharmacist, I have seen the golden age of community pharmacy come and go. While nothing says the same over the years and stays the same over the years, and pharmacy has evolved and pharmacists have adapted, the current state of pharmacy is dark and dangerous. Since the advent of PBM, business owners and corporations have seen their profit margins squeezed, penalized for issues mostly out of their control. This has stagnated pharmacists and technician wages to the point of driving quality people from the profession. In an effort to increase the profitability of pharmacy, these businesses have had to develop alternate streams of revenue just to maintain staffing and for some of their existence. Pharmacists are required to complete adherence checks, given a quota or goal-driven immunization count, legislated mandatory counseling, extensive document the use of their professional judgment, complete CMRs, provide HIV emergency counseling and medications, provide contraception counseling and prescribing, give shots and or supervise them, answer the phone, call patients and doctors about allergies or interactions, etc., and still fill and verify your daily prescription load, all without additional support, and all while maintaining unrealistic consumer service levels, meet corporate KPIs, stay off the bad list, and keep a staff motivated. This is a very long sentence to describe a day in the life of a pharmacist. It is unsustainable and extremely hazardous for the safety of our patients. Pharmacists are all about practicing up to the level of our education. It excites us and provides us a higher degree of professional satisfaction. However, we don't provide these services one at a time or move from room to room, seeing patients individually in an environment where we can give them our complete attention. We work in an environment where the phone never stops ringing, the drive-through call button is ringing, demanding our attention. 2 patients are waiting for counseling. 4 people are waiting for their flu and COVID and Prevnar shots. We're on hold with an office or insurance company, and your next pharmacist isn't scheduled for 3 more hours, and the 3 techs you have are at the out window, the in window, the drive-through, and no one is filling prescriptions. Tell me how this ends well. We are desperate for help. We need boards of pharmacy to step up, not only to protect the public, but to help the pharmacists and technicians trapped in the profession that is spiraling down the tubes because no one is helping. We are medical professionals, not automotive workers or teamsters. We care about our jobs, our teammates, and our patients. I'm looking at a retirement in about 5 to 6 years, so I can see the light at the end of the tunnel. I just hope I can survive physically and mentally and not hurt anyone or myself before I get there. I love this profession. I have loved this profession from the first day I started as a student technician. I don't anymore. Submitted with the greatest of respect. Next comment is, I'm very appreciative that this matter is getting more attention. As a future pharmacist and current intern, I believe it is important that we find a way to get work conditions and the environment in pharmacies so that which will not only promote patient safety, but the safety of pharmacists, technicians, and other pharmacy staff. I have had my share of more than below average work conditions, and it was sad. Patients were beginning to realize the company cared more about the profits than their health. It was always do more, do better, but never getting the help and resources to do so, and then being told to do better. I have had several patients tell me to quit and to find something better for my own sake. I've actually listened and happier where I am now, but I know not everyone is fortunate to have that same experience. I hope we can all work together to ensure the physical and mental health of our pharmacists and pharmacy staff and improve conditions for those that are coming into the field and those planning to stay in the field for years to come. Next comment. As a new pharmacist in the last 5 years, especially during the pandemic, it has gone downhill. As I am not a pharmacy manager but a staff pharmacist, I see the struggles of my pharmacy manager, my technicians, my floater pharmacists coming in. We have reached a point to where we are now harassing our patients for vaccinations and now bribing our technicians to get more out of them. We even receive verbal confirmations from upper management to tell us to prioritize overfilling prescriptions prioritizing, excuse me. We are even receiving verbal confirmations from upper management to tell us to prioritize vaccinations over filling prescriptions at the same time, telling us verification promise time is still not required to be met. We are a very high-tier pharmacy where we are processing 100 to 1,400 prescriptions in the Chicagoland area. This means that about 800 to 1,400 patients should be coming in a 24-hour period. Our staff on a weekday will be lucky to find at least 3 to 4 technicians to maintain a drive-through, a front counter, a filling station, not including the pharmacist also assisting all of those major functions. For me, it is not possible to pull an immunizing tech from one of those areas since I need to keep the pharmacy running. However, during the busiest part of the flu season, my pharmacy is giving vaccines almost 100 patients a day, and we are receiving at least one vaccine, not including those that receive 2 or 3. I have received backlash because even though with these type of statistics, we are below our goal. This is dangerous. This is outrageous. This is uncalled for. We have asked for help from our district manager leader due to college students leaving for a fall semester. This district manager has shown no support to my pharmacy technician manager or my pharmacy manager and walked away from the problem. They further go on with additional comments. What do I want to see? 1, we need proper plans and implementation for when a pharmacy workload is overly severe and to be working properly. We have programs in place to help, such as remote processing, reviewing, and a call center. However, these programs sometimes cause more problems and patients are angry. These need to be revised immediately to properly help a pharmacy in some way. 2, we need safety procedures into where if a staff pharmacy cannot keep up with the demands of patients, there should be something of where we can temporarily shut down a drive-through. Let this allow a pharmacy to handle the situation better instead of running it in the ground and making it worse. I've received backlash for closing my drive-through because I don't have the authority to do so. As the head pharmacist on duty, I should be able to see what is safe for the patients and my staff. Yes, putting limitations on it, but not healthcare roles should but non-healthcare roles should not be judging my decisions. 3, many of these retail pharmacies have employees who work on the floor of a location. Many pharmacies cannot call for help from anyone in the store because no one is licensed to work in the pharmacy and or refuses to come work in pharmacy. We need more versatile pharmacy workers for all hours of the day, not just the morning shift. My pharmacy should be able to page for some type of help at reasonable times of the day. Many of my arguments are solely on my experience, my emotions. However, my mental stability, my patients, and my staff are all being affected by a simple problem: staffing. I work in a I work in a food chain restaurant for almost 5 years at one point in my career before being a pharmacist. How is it that fast food places are better staffed than pharmacies? If we want to improve patient outcomes, let's improve our horrid workplace conditions. If we can properly staff a pharmacy, we can improve patient outcomes. Improving patient outcomes would lead to better metrics, but we shouldn't we shouldn't penalize bad metrics where the sole issue is lack of staff. Next statement. I feel the requirement for technician certification serves no purpose other than to pad the pockets of PTCB and leads to difficulty staffing pharmacies. As a longtime pharmacist, we survived a long time by training our technicians as we saw fit for our specific practice site. This shortage leads to a decreased patient satisfaction and potentially patient safety. And the final comment before I go back to Q&A, stop vaccine metrics and consumer experience survey metrics in retail. It's not healthcare if it's a metric and how many vaccines are given, period. Who likes to fill out customer surveys? We all know the answer to that. Limit the number of phone calls received per day. Limit the number of phone lines. We need less interruptions from the phone. 4 phone lines is crazy. We often don't have 4 employees working. We need less interruptions overall. This would be a start. Stop the sit shaming. We should have access to stools and chairs to sit as needed, not as a doctor note only option. Much of the job is mental and can be done sitting. How many scripts can a pharmacist safely check per day? Put a metric on that. With all the documentation required on opioids, checking these scripts take 3 times as long as a blood pressure medication. And the narcotic safe, do we really need to have a time delayed side? That's 2 interruptions just to get 1 drug out of the time delay side. Access to safe can add up to 20 interruptions to a pharmacist day. Those were all of our submitted online anonymous comments, which I'm glad those individuals took the time to write those out. Will this recording be emailed to participants? Yes. Once we get through the editing, we will get this on not only it'll be emailed through, we'll have it on our YouTube channel at IL Pharmacists on YouTube. All right, everyone. Is there anyone else who wants to make a comment, raise their hand, or submit a question? If not, we will consider this the conclusion of the town hall. I greatly thank everyone who stayed on through the whole course of this. I'm starting to lose my voice a little bit, so I appreciate everyone for their dedication and time, and I look forward to your continued participation and advocacy in helping us all work together for a better pharmacy profession and patient safety environment tomorrow. So thank you.